So good morning, everybody, and thank you very much for joining us for this first of the kind symposium in the MENA region that is really focusing on something perhaps that many places would read about as pathologists rather than in practice, or perhaps they might encounter a couple of cases during their training. The idea is actually to expand the knowledge and to get people to know, pathologists in the MENA region in particular, to know that really reporting of ocular malignancies, similar to reporting of breast or perhaps ovarian or uterine carcinomas, has its own mandates with a prepared checklist that include evidence-based data items that should be reported whenever we encounter ocular malignancy. Now, before we start kicking off the scientific part of the workshop, I would like just to take you through myself and Professor Sarah Copeland, who's a renowned ocular pathologist in the UK. We'll be sharing together this very short introduction into the group Histopathology, the idea of the ocular workshop, as well as a very important landmark that we're celebrating all in the MENA region, inclusive is the Diamond Jubilee of the Royal College of Pathologists. So Histopathology is an idea that started with two pathology stars working in the UK, Omar Qasid and Ahmed Ali. Later on, they were joined by Fatma al-Hashmi, and apparently what I was told later on that actually they trained together in the same hospital in the UK. Now, 2 years ago, I joined the group. I had the privilege to be invited to be part of the group, and perhaps a few months later, Dr. Iman Abdelzahir from Egypt joined the group as well. And more recently, Dr. Rand Hawari from UK as well is among the what we would like to call the board members of Histopathology. The idea of Histopathology is actually to reach out to pathologists in less privileged area in the MENA region. We all know some of the difficulties, the conflicts that are present in the MENA region that affecting all aspects of life. Of course, pathology is part of it. So we're trying to reach out to those pathologists working in the different parts of the MENA region and try to keep them updated, primarily actually with lectures and presentations through Omar Qasid focusing on breast and Ahmed Ali focusing on liver biopsies and Fatima on nephrology. And as we've managed to do a couple of, this is our second workshop, I'll be just alluding to the first workshop shortly. So Histopathology has a dedicated Zoom portal and a YouTube channel, and all members join in and deliver different types of different formats of teaching on voluntary basis. Now, in October 2021, the first breast symposium was held. It was again co-badged by the Royal College of Pathologists and was CPD accredited, and was actually attended by more than 300 participants from the MENA region in different grades of their pathology career, whether residents, junior consultants, or senior consultants. And this is our second workshop. We're proud to say that we are also co-badged by the Royal College of Pathologists, and we are also CPD accredited with 5 credit hours. And delightfully, our workshop being recognized as one of the activity in celebration of the Diamond Jubilee of the college has also been posted on the website of the college. We have 2 very distinguished speakers, Professor Sarah Copeland and Professor Bertel D'Amato, who graciously accepted to join us remotely. We hope in the near future we can host them actually in person in one of the countries in the MENA region to speak about ocular oncology and pathology. They are the experts. They are the right people actually to listen to and to grasp from their expertise and experience. And we have local speakers, Dr. Jacob Zeus, Dr. Muna Muhammad, our ocular oncologist, myself, and Dr. Jacob Zeus as pathologists joining from the King Hussein Cancer Center in Amman. And we have the delightful moderators, Dr. Omar Qasid, Dr. Fatma Al-Hashimi, and Professor Iman Abdelzahir, who will be joining, who is actually on with us today and will be moderating the sessions as we go on. I have to emphasize that actually we're in the break for Eid al-Fitr, so Eid Mubarak for everybody, but yet everybody managed to get some time off the family and the engagement, social engagements, to be able to deliver this workshop. For you now, Sarah.
Thank you very much, Maisa. So I'm, I guess, wearing a different cap as a Vice President of the College of Pathologists for Communications. And this year, as Maisa has indicated, is our 60th birthday since the foundation of the college in 1962 by it was actually opened by the Queen. So I think I can go to the next slide. Let me see. No, I can't move the slides. Oh yes, there we are. Okay, so yes, the college represents 17 different subspecialties, and it has a very broad membership of over 11,000 people. And as you can see, a good quarter of these are based outside the UK. The college is all about, it has several roles, as I'm sure you know. It is not only about exams, but obviously that plays a major role in setting the professional standards in all of the different subspecialties of pathology. But it also has a number of different activities, which includes outreach and public exchange and knowledge exchange and public education. So okay, so in January the Diamond Jubilee was commenced. We had a special edition of the bulletin. There are going to be 4 editions of the bulletin, which will summarize the various activities which are taking place throughout the year. I guess one major event will be an open day on June 21st in the new building, the new college building, which is based in Ailey Street. And there will be a whole range of different activities on that day, one being the foundation lecture, which is a college named lecture to be given by Professor Sir Jonathan Van Tam. And he is a college member, and this lecture will be live streamed and also recorded and put on YouTube, so for everybody to listen to, post filming. And there are, as I said, a huge number of activities taking place across the year, which we're hoping to be able to broadcast so that all members can benefit from. So then moving to the next. So yes, so this is on the left. This is the Carlton Terrace, which is where the Queen unveiled a plaque in 1962. And on the right, these 2 images of the college building. And you can see on the very right image, it was lit up in the colors of the Ukraine flag in support of the Ukrainian population at the difficulties they're going through at the moment. So the next slide, I think, is the last one. And this is actually on the mezzanine floor outside the Elizabeth Room, named after Queen Elizabeth. And these are all of the different portraits of the presidents of the college. And you'll possibly note that there are 3 female presidents. This is Dame Barbara Clayton, and then we've got Susie Leishman, and then Joe Martin. And very recently we being Mike Osborne, myself, and the registrar of the college, Lance Sandel, we wrote an article in the Frontiers of Medicine about these 3 female presidents and what they achieved, which was really quite remarkable. So with that, I'd like just to highlight, this Diamond Jubilee year. It's going to be, it has already been, but will continue to be a fantastic year. And I'm very pleased and honored that we were able to badge this workshop as part of the Diamond Jubilee activities. Thank you very much, Melissa.
Thank you very much, Sarah. We're certainly privileged to be that we got the support of the Royal College from the start, from the time we reached out with the program, with the idea. So enormous support all through, as we've said, and as I always like to reiterate, that one of the important missions of the Royal College, which makes it really distinguished among other professional bodies, is reaching out to its members as well as pathologists in more needy areas, trying to improve and advance pathology training and pathology practice actually across different regions in the world. Thank you very much. I think we can now kick off officially with the scientific part of the workshop. Omar, it's yours.
Good morning, everyone. Thank you, Mesa. Some of you probably know me, but for people who don't, my name is Omar Kased. I'm a consultant breast pathologist from Leicester in the United Kingdom. I know I have nothing to do with ocular pathologists, but I'm part of the organizing group. So please forgive my ignorance in the subject, but I've left it for you, for the expertise of the others. So our first talk will be delivered by Dr. Jacob Zeus, who's a recognized ocular oncologist in the Middle East, and he currently heads the Retinoblastoma service and the Ocular Oncology unit at King Hussein Cancer Center in Jordan, Amman. He completed his higher specialization in ophthalmology from Jordan University Hospital Fellowship in ocular tumors, orbital diseases, and ophthalmic radiation therapy at the New York Eye Cancer Center, and completed a fellowship in retinoblastoma and ocular oncology at the University of Toronto. Dr. Youssef has, to his credit, 65 publications in peer-reviewed journals, has delivered more than 50 conference lectures, multiple educational courses, and he is the author of a couple of chapters in the eye tumors. So you just have to excuse me for 1 second, because I need to, it's a pre-recorded session, so I will just get it up.
Good morning. First,
We have Jacob in person with us, so no worries.
I am here anyhow.
No problem. So share. Oh, where is it? It's just because it's recorded as an MP4. I was telling Mesa this morning, and it's not very easy to share. Share sound. It's all right. Is it clear, guy?
Indeed.
Good morning. First, I would like to thank Dr. Mesa Al-Husseini for putting all these things together. And I hope this will be very helpful collaboration between ophthalmologists and pathologists regarding retinoblastoma. So let's go to an overview about retinoblastoma. Retinoblastoma, as all of you know, is the most common intraocular malignancy in pediatrics and children. as a primary tumor, and it affects 1 out of 10,000 live births every year. And the most common presentation is leukocoria or white pupil, as you see in this photo here. And for tumors or cancers in general, always the priority is life. But because retinoblastoma is a cancer inside the eye, the vision will be affected as well. So there's something extra we have to pay attention to when we are treating retinoblastoma patients. Priority for treatment number 1 is life. Then we have to try as much as we can to save the eye and vision without too much side effects that may affect the life of the child. For retinoblastoma, we have a huge amount of modalities for treatment, including surgery, focal therapy, laser therapy, cryotherapy, chemotherapy, and radiation therapy. And this is customized case by case. So in fact, a treatment for retinoblastoma is very complicated, but we will try to make things in a way or another as simple as possible later on in this presentation. First of all, make sure when you diagnose patient as retinoblastoma that this is really retinoblastoma. Retinoblastoma diagnosis is a clinical. So the ophthalmologist or the ocular oncologist will look at the back of the eye, will see the mass, will see the tumor, and will tell if this is retinoblastoma or not. For example, this is a tumor that is causing this amelanotic mass with vitreous seeding, while the other eye had total retinal detachment secondary to this mass lesion underneath the retina. So we see and we diagnose and we don't do biopsy to avoid tumor dissemination and metastasis. So you have to make sure that this is really retinoblastoma before starting your treatment. Usually they present with the most common presentation, which is white pupil or leukocoria. The ophthalmologist will do examination under anesthesia, will look at the back of the eye in details, will see the mass, will see some of the characteristics for the tumor like vitreous seeds. These are characteristic for retinoblastoma. But another ancillary service may help us to confirm the diagnosis, including the non-invasive, cheap, easily available echography for the eye, or the what we call as B-scan. We see a mass with intralesional calcifications. This is characteristic for retinoblastoma as well. If you have a patient like this who presented to you with total retinal detachment in one eye, you have to look, where's the mass? Is there a mass or not? And at the same time, you look at the other eye and you see the tumor. This is in the left eye is definitely retinoblastoma, amelanotic mass with vitreous seeds, and this is multifocal lesion. So by default, the right eye should be retinoblastoma. But again, we need some support today to our diagnosis, including echography again, calcifications, we see it. And here I should mention something about CT scan. CT scan is very sensitive to detect calcifications inside the tumor, like the whitish small lesion here and this eye as well. But put in mind, CT scan for a kid will expose him or her to a high dose of radiation that may increase the rate and the chance of second malignancy. So we try to avoid CT scan for retinoblastoma patients as much as we can. The problem will come for diagnosis when we have a unilateral patient who present with unilateral total exudative retinal detachment. These are two different patients with two different lesions with two different diagnoses, which is retinoblastoma and which is not. Put in mind, the other eye in both of them is normal. First of all, it looks more white than yellow, while the left looks more yellow than white. Put this in mind. But if I cannot see, there's something very helpful that will help us to see what is behind this retina, which is the MRI. The MRI is very important to tell if there is a mass lesion or not. That looks typically for patients with retinoblastoma as a lesion that is hypointense in T2, hyperintense with contrast enhancement in T1. So it looks the opposite of the vitreous color. So this is retinoblastoma definitely. While for B, we looked at the MRI, there's funnel-shaped retinal detachment, but there is no masses, no lesions, no cancer. This is not retinoblastoma. This is Coats disease. Fluorescein may help us to show the telangiectasia at the periphery of the retina that is characteristic for Coats as well. So definitely, MRI is very helpful to confirm diagnosis of retinoblastoma or something else. Furthermore, MRI is very helpful to tell us about the extent of the tumor invasion. If we look here at this MRI, this is one of our patients who had this intraocular hyper intense lesion in T1 images that is invading the optic nerve, as you see here. So a nucleation decision was taken immediately to avoid CNS metastasis. And the pathology, as you see here, showed the mass that is intraocular that is really invading the optic nerve, as was detected by MRI. So MRI is very helpful to confirm the diagnosis and to tell us about the extent of tumor invasion in such patients. So let's look briefly about general guidelines and general rules in management of retinoblastoma. Treatment for retinoblastoma depends mainly on two factors. Number one is the tumor stage or group, and number two is the status of the other eye. The most popular and commonly used classification for retinoblastoma is the international classification, which divides tumors into groups A, B, C, D, and E. A are very small tumors and far from the optic disc or the macula. Once the tumor is more than 3 millimeter in base dimension, or it is very close to the optic disc or the macula, this is B. But in both cases, A and B, the tumor is still inside the retina. There's no subretinal invasion and there is no vitreous seeding. Once you have seeding for the subretinal space or the vitreous cavity, it is not AB anymore, it is something more. If this invasion was local, this is C. If this was massive, extensive, either extensive subretinal seeds or extensive vitreous seeds or total retinal detachment, this is D. Now, if the tumor was staying for a long time in the eye and affected the feeding vessels for the eye will start to be destroyed, and it will have some manifestations that tell us the eye is damaged, including neovascular glaucoma, tumors invading the anterior chamber, hyphema, massive vitreous hemorrhage, aseptic orbital cellulitis, phthisis bulbi. These are signs of damaged eye, and these are group E. So A, B, C, D, and E eyes, and the T and M stage came almost exactly like the international classification, but with different titles. Of course, the international is talking about the intraocular retinoblastoma. Once it is extraocular, it is not A, B, C, D, E anymore. It is something extraocular. Now, the guidelines in general depends on the stage and the status of the other eye. Number one, if we are talking about the group E eye, for example, this eye presented with a phthisis, this is group E. E eye should be enucleated immediately in general. That's for two major reasons. Number one, there's relatively high risk of metastasis because around 60% of these eyes will have high-risk pathological features that mandates further treatment. So this eye is risky. It may cause metastasis and death. Number two, the visual prognosis is almost zero. There's no visual potential for such eyes. And the eye salvage rate with extensive massive therapies is really low. It is not more than 15%. So why to try to treat a risky eye with massive treatment with low chance for eye salvage of a blind eye? So the logic says it is better to do primary enucleation immediately. So for group E, any eye present with glaucoma, phthisis, enucleation is best to be done immediately. This eye should be sent for pathologists. They will look at the high-risk pathological features, and that's what Dr. Maisa will mention today. And if there's any further treatment will be needed. Sorry. The opposite of group E is a group A. Group A tumors, by definition, are very small tumors, less than 3 millimeter in diameter, and they are far from the optic disc and the fovea. Treatment is just focal therapy. Just burn it by your laser or freeze it by your cryotherapy. The eye salvage rate is almost 100% in such cases, no risk for life. So treatment is straightforward, no need for chemotherapy. What if you have group B or C eyes? If you have group B or C, the tumor is really big. Big tumors cannot be treated by focal therapy or laser therapy or cryotherapy alone, like what we did in group A eyes. So we need the help of radiation, of chemotherapy. The chemotherapy will be given. This will make the tumor size as small as possible to an extent that it can be treated by focal consolidation therapy. Then you hit it by focal therapy. This applies for B and C eyes. The problem comes when we talk about group D eyes. In the group D eyes, the risk for metastasis is not that high. The eye salvage rate is 50%. The visual prognosis is a query. So should we try to treat these eyes if we know that we have to afford them too much therapy or not? In general, we can say it depends on the status of the other eye. If the other eye was normal or was group A that doesn't need chemotherapy, it may be better to do enucleation for the group D eye and observation for the other eye and treatment of it if there was a group A tumor. And that could be enough. Again, for group D eye ureter, we may afford the treatment if the family refused doing enucleation. Again, because the risk of for life is not that high like group E, but put in mind, too much therapy is needed for an eye with very limited visual potential. Now, whenever the best eye needs chemotherapy, don't enucleate the other eye unless it was group E. I mean, if you have a group D eye, but the other eye was group B or C, so you are giving chemotherapy anyhow because of the group B or C eye. So it's worthy to give a chance for the group D eye to be to see the response of chemotherapy. It may be good, so you can afford them focal therapy, and that may solve the issue. Again, if the other eye was a group E, regardless the status of the contralateral eye, do enucleation because group E is useless. If it was D, it depends on the other eye. If the other eye needs chemotherapy, observe, give a chance, don't do enucleation. But if the other eye doesn't need chemotherapy, maybe it is better to do enucleation for the group D eye. So this is in general. General rules just for you as pathologists to know about retinoblastoma. Number one, chemo reduction. Chemo reduction is needed, as I said, just to make the tumor as small as possible to be able to be treated by focal consolidation therapy. Chemotherapy alone in general cannot cure retinoblastoma without additional focal consolidation therapy. Chemotherapy can be given by multiple ways: intravenous or local chemotherapy to the eye, intravenous, which is the systemic chemotherapy, the local chemotherapy either as intraarterial or intravitreal. The intraarterial chemotherapy, by catheterization, you go up to the eye, put your catheter inside the ophthalmic artery, inject your chemotherapy there. You expose the eye to very high dose of chemotherapy, but the whole body will not be exposed to that high dose, so the systemic side effects will be minimal, but maybe the side effects for the eye could be slightly high, the risk of ischemia on these things, but this is one of the modalities that we use when needed. And the other modality is giving intravitreal chemotherapy by injecting the chemotherapy directly inside the eye. This is good to treat vitreous seeds, but be careful to prevent metastasis or extraocular extension of the tumor. So there's very a classical and important technique that we have to follow, which is the anti-reflux technique. Put the injection with the cryotherapy at the site of injection to avoid dissemination of the tumor. Again, intravitreal treatment is very effective for vitreous seeds. Other rules, focal therapy. Focal therapy is very important to treat the residual part of the tumor. We can give it as laser therapy, heating, as a cryotherapy, freezing, or as radiation therapy, the radioactive plaque therapy. It depends on the size of the tumor and the location, but all of them are effective in certain cases, but not effective in others, and we have to be selective which to choose. Regarding enucleation, please don't hesitate to do enucleation once indicated. Enucleation is still a good modality for treatment. You eradicate the tumor if there is no high-risk features, and if there is high-risk features you can see. It is indicated as a primary treatment for advanced cases, mainly for group E eyes, as I mentioned. After failure of treatment, and always consider very long stump of the optic nerve, not smaller than 8 to 12 millimeters, to avoid the presence of tumor at the cut edge, because this will affect the survival significantly. And always send for Dr. Maisa, Dr. Jacob, to look for the high-risk pathological features that Dr. Maisa will highlight in her talk. Regarding radiation therapy, I'm talking here about the external beam radiation therapy for retinoblastoma. We try to avoid it as much as possible because even though it is effective to kill the tumor, but it is associated with high rate of secondary malignancies that may be up to 50% at age of 50 years. So we don't want to save the life by killing retinoblastoma, but exposing the child to risk for osteosarcoma that he may die with. So we try to avoid external beam radiation therapy as much as we can. Add to that side effect, it will cause really good cosmetic impairment for the appearance of the child if exposed for external beam radiation therapy at very young age. So in general, retinoblastoma is a disease that should be diagnosed clinically. We have to make sure this is retinoblastoma. Echography, MRI are very helpful in confirming that. The management for retinoblastoma depends on two major factors, the tumor stage and the status of the other eye. We try to avoid radiation as much as we can. Chemo reduction is very important to make the tumor as small as possible to be treated by further focal consolidation therapy that could be as thermal therapy for the posterior tumors, cryotherapy for the anterior tumors, brachytherapy for medium-sized tumors, and again, please don't hesitate to do enucleation once indicated because the priority of treatment is saving life of your kid. Enucleation will not be the end of the story. The eye globe should be sent for pathologists to look at what is called high-risk pathological features, and this will be the topic for the next talk by Dr. Maisa Al-Husseini. Thank you very much.
Well, thank you very much, Dr. Yaqub, for this comprehensive talk. Now, just to be right on time, we will take the questions later when we do the case-based discussions. So I'll quickly find out how oh, yeah, there we go. Screen share has been stopped. Okay. So Maisa, it's your talk now. If you can share so I can start introducing you. So the second speaker is probably known by most of us. She is personally to me my source of inspiration, and she is the spirit of the eye histopathology group. So Maisa Al-Husseini, she's a consultant histopathologist and a full member of the King Hussein Cancer Center in Jordan. She graduated from Jordan University, Faculty of Medicine, and trained initially at Pathology Department in Jordan, but completed her training in the UK and was awarded the FRC path in 2002. She was appointed as assistant professor and a consultant at the Pathology Department in the University of Jordan. Currently a full member consultant histopathologist, neuropathologist at the King Hussein Cancer Center since 2006. In addition, currently the chair of the Institutional Review Board and Research Ethics Committee at the King Hussein Cancer Center since 2008. Also the immediate past president of the Arab Division of the International Academy of Pathology. She has more than 100 publications in a peer-reviewed international journals, as well as 5 chapters in books, including the 4th and 5th edition of the WHO book, Ocular Tumors, participating as a co-author in Retinoblastoma and Retinocytoma chapters. Has been an invited speaker at national, regional, and international conferences and workshops. So the mic is yours now, Maisa. And
thank you very much, Omar, for the kind introduction, and thank you very much, Yaqub, for setting the stage talking about the clinical part of retinoblastoma, and I'll be sharing now with you pathology. Now, I have to say something, we usually hold this type of like joint workshop at the King Hussein Cancer Center, reaching out primarily for clinicians. So usually the more weight is put on the clinical part, and pathology is usually delivered in shorter lectures. Now, what we did this time, actually, we swapped roles. So it's some flavor of a clinical, but the focus will be on pathology. So this is the outline of my talk, and I'll be starting actually with a very important issue, which is orientation of the eye globe once received. What are the landmarks that we should look at? Actually, if you want to orient a globe received for dissection at the pathology lab, you have to start from the back side of the globe. So you locate the optic nerve, then the superior oblique muscle, which is usually located superiorly and more to the temporal or the lateral side of the globe, and the inferior oblique muscle, which is located more inferior as well as to the temporal or to the lateral side of the globe. And then we have the vortex veins, and importantly, the long ciliary vessel. Once we orient once we locate these important landmarks in the globe posteriorly, we can then know or confirm whether this is the side, the laterality of the globe, right or left. And this is again repeated for the right globe, looking for the optic nerve and then the superior and inferior oblique muscles, which would be more towards, slanted more towards the temporal side or the lateral side of the globe, and then into the long ciliary vessels. And this is how we orient our gross specimen. Now, it's very important to be aware of the main landmarks of the histopathology of a globe. Now, importantly and luckily, the eye, the whole globe, and I'm going to talk about the dissection, important landmarks for the dissection. The whole globe fits into one standard slide. So we can actually be oriented to the different structures with the low power magnification. Now, looking at the cartoon here on the left side, let's start from the very inside, from the inner side of the eye. We have the yellow part here, which is the retina, and this is usually almost this bluish colored structure in the pathology, in the real pathology slide. Importantly, now the retina actually continues as the optic nerve, and I'm going to allude on this further with some clarification, and gets directly to the central nervous system. This is why involvement of certain areas within the optic nerve carries important prognostic effect or impact on the treatment and the outcome of the patients. So we have the retina, and this is followed, the second layer is the choroid, and it's actually colored in brown because of the pigmentation that is really the hallmark. The pigments as well as the vessels are the hallmark of the choroid layer within the eye globe that continues as the ciliary body and the iris, which is the colored part in the eye. And this is all together collectively, those pigmented layers are called the uvea. And then we have the last part of the globe, which is the sclera, which is white in color. And anteriorly, it continues as the cornea. Posteriorly, it continues, it's connected to the meninges, in particular to the dura. So we can now understand how important is, or we can imagine how important is the involvement of the different parts or the different layers actually of the globe and its implication on the outcome of retinoblastoma patients. Now, there is an important landmark here that I'll be alluding to, which is the part where the optic nerve would pierce into or through the sclera to get into the central nervous system. Now, the histology of the retina, the retina is composed histologically of 10 layers. What is really important, it's remembering them is not the issue. What we need to remember are two things. Number one is that the retinal pigment epithelium here is actually contains a pigment, contains melanin, but it's not part of the choroid. So invasion of the retina until the retinal pigment epithelium does not mean that there is a choroidal invasion. Choroid is actually this part that is rich in blood vessels as well as in melanocytes in pigment. Now, the different layers actually between the photoreceptors, the inner and outer nuclear layer, the plexiform layers, and so on, will all commence into the ganglion cell layer that will lead the processes of those ganglion cells will all converge to give us the optic nerve. So actually the axons, the optic nerve, which is composed primarily of axons, the cell bodies of those axons are the ganglion cells, which are located within the retina. So this is the structure, or under the microscope, how does the optic nerve appear? So it's mostly the axons as well as the glial sheet that surrounds the axons, as well as the meninges. And this is a higher power magnification. So these are the axons that compose the optic nerve, as well as the arachnoid pia. And then we have the somoma bodies, and this is the dura, which is in continuation with the sclera, as I have just mentioned. A very important part that we should always look at carefully, and you'll hearing me talking about it repeatedly, is the part where the nerve fibers from the retina would pierce the sclera into a landmark called the lamina cribrosa. This is called so because it looks like مثل المصفاية بالعربي. It's so pierced, it has many holes, allowing for the nerve fibers to get access into the centrally into the central nervous system. So it's very important to remember that the optic nerve at an entrance into the central nervous system is divided into like 3 zones: the pre-laminar, the laminar, and the post-laminar tissue. And this has important implications related to the classification actually and the staging of retinoblastoma. Now, crossing of the globe, remember that this is what the ophthalmologists see. This is exactly what Dr. Yaqub mentioned, leukorrhea, which is the most common presentation. And quite often is actually this is picked up when parents or people nowadays with the smartphones take photos. So the child would have, instead of the red reflex, would have a white reflex, and this is what we see pathologists. This is the globe dissected, and this white fleshy tumor is the retinoblastoma. But before grossing, please, it's again, as is the case with other organs, before just making dissecting or cutting the specimen, make sure that there is enough clinical data present on the request form, including the stage, clinical stage, laterality of tumor, and importantly, any history of previous therapy for the inoculated or exenterated eye, the status of the other eye, family history of cancer, correlation with the other ancillary studies, including, for example, the CT scan and MRI and so on. So we start grossing the specimen, as I mentioned, with orientation and measurements. So we have to make sure that what we received really matches the form that accompanied the globe to the pathology department. An important and yet perhaps not very well appreciated technique is a transillumination of the globe in a dark room in order to try to locate the tumor, the area where the bulk of the tumor is present. And why is that so? Because this has important implication when we cut our main sections within the globe. Now remember, as Yaqub Yaqub has mentioned, it's very important to actually measure exactly the length of the optic nerve obtained as part of the inoculation, and because it has, in a way, it's like it has. You're giving a feedback, indirect feedback to the ophthalmologist on the adequacy of the surgery, as well as the potential, if there is a potential involvement of the optic nerve. Now, it's very important that this part of the optic nerve, the surgical resection margin of the optic nerve, is sampled before really incising the globe to make sure that there is no contamination. You know, retinoblastoma, it's like the medulloblastoma or like a neuroblastoma, very fluffy, very fragile tumor. So once we open it, there is a potential for contamination of the bits and pieces from the tumor around the globe or into the margin of the optic nerve, which would make really further staging difficult, which, as I've mentioned, really has important implications on the management and the outcome of patients with retinoblastoma. So sectioning, remember that we have to make sure to include a seminal or the most important section of the excised eye, which is what we call the pupillary optic nerve section, or the PO section. So this is in guidance from the trans-illumination, in which we located the largest diameter of the tumor. We have to take a section that would include the optic nerve as well as parts of the pupil, a transection containing or aligned in the direction of the largest diameter of the tumor. So we will end up actually with 3 sections. We have the PO section, we have what we call the superior part, the remaining part of the globe, what we call the superior callot, and then the inferior part, inferior to our sectioning, which is the inferior callot. And this is how we really put them or align them in our cassettes. So we have the resection margin, which was obtained prior to any incision of the globe, the PO section, as well as the superior and inferior callots, which would be bred low, cut in serial sectioning and placed into different cassettes. Now, more recently, and because of the increased importance of genetic testing, nowadays we try to obtain samples of the tumors of the globe before being placed in formalin, in fixation, and because of that, communication with the ophthalmologist, with the ocular ophthalmologist, is extremely important. The classical way is to do a small incision and then to insert trephine biopsy and to obtain a small part of the tumor, and then just fix the tumor in the fix the globe in the traditional way and section it in the traditional way. Now, importantly, when we are doing the sectioning, and as I've alluded to before, the whole globe and the PO segment, which is the single, perhaps most important part of the whole sectioning, can fit into one slide, and we need to take at least 10 up to 20 sections examining the this in particular section to make sure to evaluate in particular any involvement as well as the degree of involvement, if any, of the optic nerve. Usually the optic nerve as well as the superior and inferior callots, we get 3 deeper levels. So this is the blocks that we have, and these are the resulting slides that we should examine. Now, microscopic reporting of retinoblastoma. Again, the role of pathologist has evolved in retinoblastoma like all other tumors within the body. So most often, the 99.9% of the time, the ocular, the ophthalmic oncologist would be aware and knows that he's dealing with retinoblastoma. So it's not only to confirm the diagnosis, but also to look at high risk, histologic high risk features, which I will allude to, as well as sorting the differential diagnosis, and of course, as a complementary part of the pathology role is correlation with other diagnostic modalities. So confirmation of the diagnosis, perhaps this is the easiest part. Retinoblastoma is a small round blue cell tumor that usually has large areas of necrosis associated with dystrophic calcifications that are detected by the different modalities, as Jacob mentioned in his lecture. What is really important after establishing the diagnosis is establishing the degree of differentiation of the tumor, or what we call, similar to other tumors in the body, the grade of the tumor. And in a grading of the tumor, we have to look into the presence or absence, as well as the percentage of any rosettes. There are three types of rosettes in retinoblastoma. The easiest one is the Homer right rosette that we see in other types of small round blue embryonal tumor, like medulloblastoma, for example. Usually, these are tumor cells surrounding fibrillary matrix in the middle of the rosette. What is really special about the rosettes or retinoblastoma are the ones on the left and right. The one on the left side is the Flexner-Winterstein rosettes, and these are in a way similar to the true rosettes of ependymoma within the central nervous system. So we have a canal, empty canal usually, surrounded or by the retinoblastoma cells rosetting around this canal. And in a way, this is recapitulating the true photoreceptor differentiation of retinoblastoma. On the other hand, on the far right side of the graph is a special type of rosettes, mittel ba'til warid, florets, similar to a bouquet of flowers. And this indicates an advanced photoreceptor differentiation and is usually associated with better differentiated tumors, lower grade or better differentiated tumors. Now, if we see the florets, this is in a way pathognomonic for retinoblastoma / retinocytoma. If we see a combination of the Flexner-Winterstein rosettes and Homer right rosette, this is really pathognomonic of retinoblastoma. Homer right rosettes alone cannot differentiate retinoblastoma from other embryonal tumors. So, for example, this is actually from one of our cases, a tumor that is associated with more than 50% rosettes, and this is considered to be like well differentiated grade 2. On the other hand, we have to look, in addition to the differentiation, into a more recent cellular description of retinoblastoma, which is anaplasia. And again, this is in a way similar to medulloblastoma, to brain tumor, where the concept of anaplasia has evolved over the time. And in a way, again, the definition of anaplasia in retinoblastoma in a way is similar to the definition of anaplasia in medulloblastoma, in which we have large-sized nuclei. Usually, we have to have an internal reference to compare to, usually perhaps an RBC 3 times the size of RBC or more, associated with large number of mitoses, apoptosis, as well as rhomboid shape or molding, or even cannibalism, one tumor cell eating the other. So this is a tumor in which there is no anaplasia at all. On the contrary, there is an evidence of good differentiation, perhaps with the floret formation. This is a tumor with mild degree of anaplasia with the Flexner-Winterstein rosettes. This is a grade 2, and this is the highest grade of anaplasia that we encounter. And this is actually a case, a higher power magnification, depicting the features of anaplasia. Again, this is an RBC, our reference. So this is the size of the tumor cell is at least 3 times the size of an RBC, with lots of mitosis, necrosis, and apoptosis. Now, one, again, more recent feature that is being described in retinoblastoma that has not really been described before is the presence of MEK amplification instead of retinoblastoma amplification, and the tumor would assume an appearance more or less similar to neuroblastoma rather than retinoblastoma. The nuclei are usually round, vesicular with a prominent nucleoli, and this is usually occurs in infants and associated with dismal outcome. Now, once we establish that this is a retinoblastoma and this is the degree of differentiation with or without the presence of anaplasia, we have to look into the histologic high-risk features. Why are these important? As I've told you, most likely, if you write down in the report, this is retinoblastoma, well, the inoculation has been done initially because they know, and they'll be right in most of the cases that this is retinoblastoma. What they really need from pathologists is really to report on these. And any pathology report that is deficient in reporting high-risk features is considered to be inadequate pathology report. Why are these important? Because they are associated with increased risk for metastasis. They would upstage the tumor. They would affect the outcome of the patient, as well as will determine the need or not of adjuvant treatment, including chemotherapy, radiotherapy. What are these high-risk histologic features? Number one, optic nerve invasion. And this is where we're going to revisit the issue of the laminar pre or post-laminar optic nerve or tumor location within the optic nerve. Choroidal invasion, this is the brown layer within the globe. The intrascleral invasion, this is the white layer in the globe, or extra or episcleral invasion, and invasion of anterior chamber structures of the globe. So let's start with perhaps one of the more frequent encountered high-risk features, which is optic nerve invasion. It's highly indicative of death from metastatic retinoblastoma, and it's most often, if it happens, will be associated with dissemination to the central nervous system. And according to the level of invasion, this is divided into 4 groups. And this is the image that I showed you, the cartoon I showed you previously. And this is exactly how the appearance looks like under the microscope. So we have the retina, we have the pigmented layer here, which is the choroid, and then we have the sclera. And this is the optic nerve converging, the fibers converging to pierce into the lamina cribrosa, this fenestrated component to gain access into the central nervous system. So the part of the optic nerve which really pierces through the lamina cribrosa is called the laminar part of the optic nerve. The one that is before is called the prelaminar optic nerve, and the one that is after, which is almost marked by the end of the sclera, the edge of the sclera, is called the post-laminar. Now, why this is important? Because a tumor, retinoblastoma, can have no evidence of invasion into the optic nerve, and this is considered to be group 0, or invasion into the prelaminar or laminar, so it's at the boundaries of the sclera from the edges, and this is considered to be group 1. Post-laminar, which has really penetrated into this part after the lamina cribrosa, this is considered to be group 2, and then this is where the optic nerve margin is involved by tumor, and this is considered to be group 3. And this is actually reflected on the stage of the tumor. So going from PT2 into PT3 into PT4, depending on the degree of involvement of the optic nerve. High-risk feature number 2, choroidal invasion, has a very strict definition. So remember, the choroid, this is the retinal pigmented epithelium. So this is not where we're looking for invasion. We're looking for invasion at this vascularized and pigmented layer. And once we have involvement, the small round blue cell tumor, which is the retinoblastoma, will dissect in between the blood vessels and the melanocytes. Because of that, we can see them in a way splayed out. So we have the tumor cells intermixed with the pigmented epithelium as well as the vessels, resting on this hard, tough part of the globe, which is the sclera. Now, the choroidal invasion is defined as the presence of one or more solidness of tumor cells that fill or replace the choroid and has pushing or infiltrative border. This is not enough. We have, once we establish the presence of choroidal invasion, we have to define whether this is massive or focal. So let's start with the massive. The massive is defined as the presence of solidness more than 3 millimeter in width, or in thickness, or the presence of multiple foci of choroidal invasion that would summed up will be totaling into more than 3 millimeter. And usually, although this is perhaps not a strict mandate, but usually it touches the edge of the sclera. Now, if these are not fulfilled, then we're talking about focal choroidal invasion. And why it's important to differentiate, because again, this is clearly reflected on the stage of the retinoblastoma in terms of the choroidal invasion. Now, unfortunately, if the patient is unfortunate enough to have invasion of the retinoblastoma beyond the choroid, the pigmented part, into this tough part, the pink part, the dura-like part, which is the sclera, then this is intrascleral spread. And this is, again, affects the staging depending, this is PT3C or PT3D, depending whether we're talking about a partial or full thickness involvement of the sclera. And then the very unfortunate patients, the ones who would end up having extrascleral, outside the globe, extraocular invasion of the tumor. And if you look at this tumor, perhaps just trying to sum up what we've just mentioned. So we have, this is the optic nerve, and this is the edge of the sclera. So this is really, we having a post-lamellar optic nerve invasion. It appears that there is evidence of massive choroidal invasion more than 3 millimeter, as well as actually piercing of the sclera and spreading outside. And this is associated with the worst overall prognosis and is considered to be PT4B, similar to cut margin involvement of the optic nerve. High risk feature number 5 is involvement of the anterior or invasion of anterior chamber, whether this is in the ciliary body or in the iris or in the other structures within the anterior chamber. Now, once we report on the confirm the diagnosis of retinoblastoma, establish the grade, comment on anaplasia, look meticulously and carefully into the presence or absence and the degree of, if present, the high risk features. Then we look into, we can report other less important features, but usually they are mandated as per the protocols of retinoblastoma. So what are the other features? For example, one of those is the growth pattern. Is the tumor primarily growing inside towards the vitreous, or actually outside towards exophytic, towards the sclera, or perhaps it has a mixed growth of pattern? Some important pattern of a growth is the diffuse infiltrative pattern, and this is actually important for pathologists as well as ophthalmologists to be aware of, because usually patients will not present, as is seen here, for example, with leukorrhea. They will present with features that would suggest inflammation to the eye, and because of that, usually these are associated with delayed diagnosis and sometimes dismal outcome. One important modality or form of growth of retinoblastoma is the presence of true multifocality, which would indicate germline mutation. Once we have an eye globe dissected and presented to us for examination, we have actually to try to make sure that this is not something else, not a benign pathology like Coats disease or toxocara, endophthalmitis, or malignant, some other type or form of malignancy, in particular medulloepithelioma. Now, despite similarity of names, medulloepithelioma in the globe does not have any similar genetic or common genetic background with medulloepithelioma of the central nervous system, which is nowadays considered part of the embryonal tumors with multi-layered rosettes. So it's only the names, molecularly they are completely different.
Yes. Sorry to interrupt you. We're just passing the time, yeah?
I'm almost done. A very important issue to consider is, as I've mentioned to you, the history of treatment of retinoblastoma. Why so? Because sometimes what we will end up with receiving at the pathology department is actually a scar with calcification, with differentiated cells, with cholesterol cliffs, but no evidence of a tumor. And we might misdiagnose this case as, for example, Coats disease. So this is where the integration with other collaboration with other disciplines is extremely important. Communicating with other with ophthalmologists and radiologists is extremely important. Now, what I've mentioned all is really reflected on the staging of the retinoblastoma through the eighth edition of the TNM. And we have reporting checklist present or produced by the Royal College of Pathologists as well as the College of American Pathologists. Correlation with other modalities is extremely important, and this is the exact example that Jacob shared with you earlier. So this is the MRI, and this is the exact pathology we managed to get exactly depicting exactly the MRI appearance. What I would like to conclude with is really the very active service of ocular oncology that we have at King Hussein Cancer Center, which has resulted in so many publications in this particular example on the screen relating to retinoblastoma. So in conclusion, it is highly recommended that retinoblastoma inoculation specimens are handled by ophthalmic pathologists working in specialized reporting centers, and the pathologist's role is really important in confirming the diagnosis, but perhaps the most single important factor is establishing the presence or absence of high-risk features, and MDC work and teamwork is the key for success of these services. Thank you very much.
Thank you, Maysa, for this impressive talk as always. Now, now we get to the part which is a case-based discussions, and this is going to be a joint session by Dr. Jacob and Dr. Maysa. We will keep the questions at the end, so if you have any questions, please type them in the chat box, and I would kindly ask the presenters please to keep an eye on these questions and probably either answer them live or by typing directly to the candidates. Thank you very much. I'll leave you to it.
Thank you very much. So now we'll move into really how those didactic lectures or theory would really translate into a practice by presenting perhaps a couple or three cases depending on the time. So we'll start with the first case. This is joint between me and Jacob. Tfaddal, Jacob.
Okay, thank you very much. The first patient, he was a 2-year-old boy who presented with right leukocoria or right white pupil and intermittent exotropia in the same eye, and that was 6 months prior to presentation. There was no family history of retinoblastoma for this child. And next, please. Now, this is photo for the patient from outside. As you see here in the right eye, the pupil looks white in color, while the left pupil looks normal. And when we looked at the back of the eye for the right eye, we found this huge amelanotic retinal mass that is associated with a lot of hemorrhages. There was a new vascularization of the iris. This tumor was really big that it is touching the posterior surface of the lens. In fact, when we looked at the left eye and the other side, there was nothing big, but there was very, very small inferior tumor. If you look inferiorly, there is this white small lesion. This is small tumor. So in fact, this patient has bilateral retinoblastoma. The right eye is a group E because there was a new vascularization of the iris. The tumor was touching the posterior surface of the lens. And the left eye was a group A because the tumor is smaller than 3 millimeter in diameter and it is really far from the optic nerve and the fovea. Now, when we did B-scan or ultrasonography for the right eye, we found a mass inside the eye,
And if you see these whitish spots inside the mass, these are the calcifications, which are very characteristic for retinoblastoma. So in fact, we have an intraocular retinoblastoma with calcifications. The tumor is really big, so this is group EI. So if we go back to our guidelines, in general, group E is preferred to be immediately enucleated to avoid metastasis. In fact, for this case, we did MRI as well to show not only to confirm the diagnosis, but also to give us an idea about the extension. And there was an MRI in the right eye. This is a huge mass that looks the opposite color of the vitreous. So in fact, it is in T1 images is hyper intense, and it is hypo intense in T2 images. And the bad thing that there was something suspicious for early optic nerve invasion. So intraocular retinoblastoma, group E with suspicion for optic nerve invasion, this is a case for immediate enucleation. So the decision was, or the impression that was, bilateral retinoblastoma, the right eye was group E with suspicion for optic nerve invasion, the left eye was group A. So the plan was to do immediate enucleation for the right eye and the cryotherapy for the left eye for the group AI. So what we did is enucleation immediately, and we treated the left eye by focal therapy alone. And now for the pathology for you, Dr. Maisa.
Thank you, Jacob. So this is actually courtesy of Dr. Jacob. This is what the globe, the PO section, once dissected. It's very nice if we correlate with the images here. Look at the hemorrhage here as well as the large tumor, and just this is exactly matching of what we're seeing. This is the large area of the hemorrhage, and this is the tumor. And as you've mentioned, it's really touching mazboot, the posterior, the lens, the posterior aspect of the lens. This is the optic nerve. Of course, the optic nerve, as I've mentioned, would have been longer, but because what we really do at the very start is measuring the optic nerve, taking the resection margin, and then opening the globe عشان هيك ببين الأوبتيك nerve shorter. Now هي الإيمج هذا صار عندكم الراديولوجي. This is the gross, and this is like a very scanning power magnification of the tumor. So this is of the globe. This is the lens. This is the cornea. This is the tumor. These are the areas which appeared really red, and this is the optic nerve. So let's go into higher magnification. So أول شغلة بنشوفها, the first that we see is lots of rosettes. So perhaps this is really a good, probably this is retinoblastoma, and this is a lower grade tumor. What are the types of rosettes that are present? This is higher power magnification. We can see here that there is a tendency or attempts at forming canals, and here is more even evident, and it's better appreciated here. So we have the Flexner-Winterstein canals or rosettes. We have areas of necrosis. We have some pigment here, apoptosis, and then we have the Homer-Wright rosettes as well. And when we look a little bit further into the cellular detail, there is some degree of anaplasia. So this is not a widespread diffuse anaplasia. There is tendency for molding and perhaps cannibalism. So this is like a grade, perhaps a grade 2 anaplasia. This is more of this is a higher power magnification on the size. We can appreciate the size of the tumor cells as well as the presence of wrapping, squaring, rhomboid appearance, as well as apoptosis and scattered mitotic figures. So this is retinoblastoma that is probably grade 2 with some degree of anaplasia. What about the high risk features? Number one that we look at is the presence or absence of choroidal invasion. And this is actually a low power magnification of the choroidal invasion. Now remember, the diameter of the low power lens in our microscopes is around 5.5 millimeters. So with this being really from one side to the other, occupying the whole diameter, so definitely this is a solidness of retinoblastoma that is more in excess of 3 millimeters. So this is massive choroidal invasion, and this is on high power magnification. And as I've told you, there is a tumor cells that are interspread in between the sprayed melanocytes as well as the vessels of the choroid, and this is the retina. This is high power magnification of the massive choroidal invasion. Optic nerve, remember what Jacob said, there was a suspicion for optic nerve involvement. So this is a low power magnification, almost a scanning power of the optic nerve, the whole length of the optic nerve. And this is the area where the optic nerve fibers would converge to become the optic nerve. And this is the sclera. Okay, so these are perhaps the limits here of the lamina cribrosa. So this would be probably an involvement of the laminar part of the lamina cribrosa, not going beyond that. This is higher power magnification, and I've tried really to take some photos to show you that this is the edge of the sclera, and this is exactly the line which we would imaginary line that we would draw to confirm that this is laminar or a pre and laminar involvement rather than post laminar involvement. Now, other features that we would look for when we examining the tumor, the calcification in correlation with what was really described previously, as well as areas of necrosis, which we know that all embryonal tumors are prone to develop necrosis and calcification. And this is most of the tumor has actually grown. This is the pigmented epithelium of the retina, and this is most of the retina has been lifted up, or صار في عندنا retinal detachment with some fluid beneath the retina. And in parts of the tumor, I thought that this might really be consistent with a precursor lesion that sometimes we find in retinoblastoma, which is retinocytoma, a better differentiated part of the tumor that, if accumulates further mutations, would develop into retinoblastoma. So this was the pathology report for this case. So this is the right eye. This is the exact description of the macroscopic features. And this is the checklist or database formatting for reporting of retinoblastoma. So we describe the type, the grade, the other structures involved, the growth pattern, extent of optic nerve invasion, and other pathological features. And then we sum up all the anaplasia grade, anything to suggest the MEC in amplification. And then the final line is really, they know that, as I've told you, the ocular, the ophthalmologists, do they know that this is retinoblastoma? A grade is important, but it is not one of the core elements. What is really needed from us to precisely place the stage, depending on the presence or absence of.
Sorry, the report is not showing,
لا sorry اوكي خلاص ماشي لانه هايبر لينك خلاص اوكي fine sorry
that's all right. I just want to make you aware of the time as well. Yeah,
okay. So this is for the first case. Now moving into the second case.
Okay, now the first case was a straightforward case actually. Now the second case is not at all. Now he was a 4-year-old boy who has history of bilateral retinoblastoma at the age of 2 years. He was treated outside Jordan. He received 13 cycles of systemic chemotherapy and didn't receive the adequate focal consolidation therapy that is needed. Then after treatment failure, the patient was referred to us. As I said in my presentation, chemotherapy alone cannot cure retinoblastoma, and focal therapy was not applied for this child. Now, because this patient has really significant delay and he received too much chemotherapy, he presented with bilateral, really advanced intraocular retinoblastoma. Both eyes were group E. The right eye had anterior chamber hemorrhage, hyphema, and the left eye was phthitic with NVIs, new visits in the iris. So actually, this patient presented with really too much advanced bilateral retinoblastoma. Both of them were group E eyes. And this is something we really hate to see. Next, please. Now, we decided to do MRI first to see what is the extent of the tumor, and we did metastatic workup initially. Now, when we looked at the MRI, the tumors were huge in both eyes, and there was suspicion for an early invasion of the optic nerve in both eyes, and the left eye looks slightly phthitic. The right eye had huge mass inside the eye. We decided to do metastatic workup, CNS analysis, bone marrow, all were negative, and the family refused totally to do enucleation. In fact, I told them that these eyes are useless. They will be blind. This patient will be blind forever. No way to gain some vision. The tumors are risky because they are invading the optic nerve. So both eyes should be enucleated immediately if I want to save the life of this kid. Now, the parents refused totally this decision, and they preferred for the patient to die with both eyes better than surviving with no eyes. And at this point, I have to give them an option, because if I leave them without a treatment, they will get back with extraocular invasion, orbital invasion, and very high morbidity for this bad disease. So we decided, okay, what is the way that may give him some chance to save his life? We decided to do bilateral external beam radiation, which is a modality, in fact, that we don't like to do, but in such cases, we have to. So we did external beam radiation therapy for both eyes. And after 4 or 5 months, he came back to us with next, please, with excellent regression in the size of the tumor in the left eye. But there was a dramatic progression in the right eye. So with the new images, the right eye has active retinoblastoma that is invading clearly the optic nerve. As you see in T1 images, there's optic nerve invasion. While the left eye, there's no residual tumor that we can see, and the optic nerve looks clear. So I sat down with the family. I said, listen to me. Maybe we could save the left eye, even though it is blind, but the right eye is very, very dangerous. Now there is mega progression for the optic nerve invasion. So we have to do enucleation. We have no choices. At that time, the parents accepted to do enucleation. Next, please. So this is just to compare the MRI before the radiation and after the radiation. Before the radiation, the right eye showed a huge tumor that slightly regressed, but the optic nerve part progressed, while the left eye showed good regression. So we did enucleation for the right eye.
And again, this is the section, the PO section of the right lobe with a huge tumor. And perhaps here an area of optic nerve involvement. Remember that the margin is always sampled initially before attempting at opening the globe. And this is again the scanning power magnification. And perhaps now you're more oriented. This is the lens, this is the cornea, this is the anterior part, this is the huge tumor, and this is the optic nerve, highly sclera. This is where it converges into the central nervous system, the dura. And what do you think? The tumor, does it involve the optic nerve or not? It does. Is it at the level of lamina cribrosa before or beyond? So it clearly, in correlation with the radiological findings, it's really beyond post lamina cribrosa, but not at the margin. So first of all, confirming the diagnosis, there are tendency for some rosette formation, definitely not as widespread as the first example, with necrosis and apoptosis and more solid growth areas. So this is not as well differentiated as the initial case. And this is low power magnification of the optic nerve. And I think this is perhaps for pathologists, unfortunate for the patient, but for pathologists, it's among the easiest to diagnose post-laminar invasion. It's very important, once we establish the diagnosis or involve this high-risk feature, we have to measure the distance from the advancing edge of the invasion to the very cut margin of the optic nerve. يعني بمعنى آخر, other words, how much is of the optic nerve is free of involvement of the retinoblastoma. And again, here to show you at higher power magnification, how the tumor, even at low power, it's very dark, does not show much evidence of differentiation, lots of necrosis, and then into the massive invasion into the optic nerve. This is our landmark. This is the sclera. And this is if we draw a line, most of the large part of the tumor is moving or growing or invading beyond the lamina purpurosa, and this is where we have to measure the distance from the advancing edge until the cut margin. Remember that the very cut margin, the donut or the disc of the optic nerve has been submitted in a separate cassette and reviewed separately because it affects the prognosis. Another feature that is very important, choroidal invasion. So again, this is the pink, this is the dura-like, this is the sclera, and this is where the tumor intermingle with vessels as well as pigment, and this is an evidence of choroidal invasion with measurement. This is massive choroidal invasion, but unfortunately, this was not only the case. The tumor grew beyond the choroid into invading into the pink part of which is the sclera, and even this is the sclera tumor before and tumor after. So the evidence was that there is also a tumor growing outside the sclera or into the scleral space, and there was evidence of as well involvement of the parts of the anterior chamber of the eye globe. Okay, so this is where part of the ciliary body and the iris are. So unfortunately, I cannot play or show you this was through hyperlinks. So this is exactly what was reported for the second case. Omar, do we have time for a third case, or should we stop now?
I think, it's better to stop because that
Sure.
will give us some time, to reflect on this bigger part of the presentations. So let me go back to the chatter box, which I can't find now. Yeah. Sorry, I just want to. For some reason, the chatter box says.
So I have it actually with me here.
Oh,
so
there we go. No,
okay.
I got it now.
Sure.
So I think the first question is from Professor Coupland. So I think it's directed to Jacob. How many cases of retinoblastomas do you see, and what proportion of stages do you see? What's the most common?
Yes, we see around 25 to 30 new cases every year. Half of them are group D or E. So we can say half D and E, which is advanced intraocular, while the other half is less advanced, which is ABC.
Right. Okay, so the second part, I think it is it's more kind of dilemma problems. So it's from Basma. So the dilemma of verifying presence / absence of scleral invasion. Do you look for it immediately in the vicinity of the tumor, i.e. just above the tumor? I think this is to Mesa.
Again, sorry, Amr.
So the dilemma of verifying presence and absence of scleral invasion. Do you look for it immediately in the vicinity of the tumor? I mean, just above the tumor?
It's actually anywhere. It doesn't have to be in the vicinity of the tumor. You can see it actually clearly if there is a scleral invasion. Quite often it follows the vessels as well as the tracks of the nerves, for example. So adjacent to the tumor or away from the tumor. Most often, I have to say, and perhaps this is where Professor Sarah can, with her experience, can also comment on. Usually this is around the areas where there is the massive choroidal invasion or in continuity with that, but it doesn't have to. It can be anywhere. Professor Sarah, what do you think?
No, I agree completely with what you say, and it more often not. if once you've got infiltration into the choroid, then like you see with other tumors, the tumor cells use the exit routes that pass through the sclera, and these are typically nerves or blood vessels, and so they can run parallel to those and then exit extraocularly. So it's very important to look for not only the extent within the choroid, but is there any sort of seeding going along these exit routes within the sclera?
There's one question from Dr. Ruffin, and that is in regards to the fixation of the specimen. She's asking how long, do we have to fix it for, and is it similar for other biopsies?
The answer is yes. Usually it's preferable to have the fixation up to 48 hours. And it's amazing because despite the presence of the thick and tough sclera, yet the globe and the tumor tend to fix really well. So it's usually, the recommendation is 48 hours actually. The fixation is for 48 hours.
Right. So there is another question. I think it's for you, Mesa and Sarah. And this is to explain the endophytic and exophytic growth pattern.
This question has some clinical and other pathological impacts. So I would like to answer the clinical part. And
please go ahead.
Yeah, clinically, endophytic is a tumor that it grows directly towards the vitreous, while exophytic, it grows toward the sclera. So if it is growing toward the sclera, usually they come with retinal detachment. So in some cases, we don't see the mass, we see total retinal detachment, exudative retinal detachment, and the mass is underneath the retina. While for endophytic, the growth direction would be toward the vitreous. So we see the mass in front of us and a lot of vitreous seeding or something like that. Pathologically, that I would leave for Dr. Mesa.
So it's actually a reflection of what you've said. I'll try to get into the presentation and perhaps share this slide in particular that talks about the growth pattern. And actually we have a publication, one of the publications that came out from King Hussein Cancer Center was in relation to the effect of the growth pattern on the outcome.
Yes, the impact of the growth pattern.
Yeah. So this is so if the tumor, it grows endophytic, a tumor, it grows towards جوا العين, inside the eye, towards the vitreous, towards the anterior part. The exophytic is actually where it lifts up the retina, and the tumor, most of the tumor growth is behind the retina, towards the sclera. And this is what Jacob was saying. In these cases, because of the resultant retinal detachment, perhaps clinically, what would they will see is retinal detachment without being able to appreciate the presence or absence, as well as the size of the tumor. Right, Jacob?
Correct.
Yeah. And then perhaps most often what we see is actually the mixed growth pattern, in which we have part of the tumor growing behind the retina, causing retinal detachment, and part of it grow towards the inner part of the globe, inside the globe, where the vitreous humor is. Okay, so this is the endophytic and exophytic tumor. It has some effect on the outcome, impact on the prognosis, but is usually not as important, is not considered to be one of the pathological or histological high risk features. Okay, it's important to report on, but missing reporting on the optic nerve involvement or the choroid involvement is far much more important or has implications أكتر كتير من missing to report the growth pattern of مرات كتير, many of those items are actually also important for correlation studies. So you know that the radiologists always strive to enhance their correct report and their proper reporting. And the way to do it is actually to correlate with the gold standard, which is considered the pathology. So it's not part of it, of course, the vast part of it, the major part of it is for the sake of the patient, but the small part of it is also to enhance learning and advancement of other disciplines or other techniques.
Right. Okay. Thank you, Mesa. There are a couple of special requests for synoptic report. One of them is from my dear friend, Dr. Bombal from India. So what you can do, Mesa, for case one, you just drag it from your whatever desktop and put it right in the chatter box where we type, okay? And that will share it with the others so they can click it and view it, yeah? And you can do...
Actually, I have it here, okay? So this is exactly how we report the retinoblastoma, the cyanotic reporting.
Yeah, so I think Dr. Bombal is also asking about the comments of on molecular profiling of the tumor. So in your report, basically.
I leave this part for Yaqub to answer, to take care of.
Yes, actually, the molecular part is not part of the pathology part. This is totally something different. And then for retinoblastoma, when we do genetic testing, we know ahead of time that if this patient had bilateral retinoblastoma, that this is 100% is germline disease. While if it is unilateral retinoblastoma, 15% would be germline and 85% would be sporadic. So what we do, we don't need to do enucleation for every single patient to know the genetics. If this was a bilateral disease, we look at the blood of the patient, we do DNA extraction, we send for molecular pathology, molecular biology, and they will tell if there is RB1 gene mutation or not. If there is, and if this was bilateral, definitely we will find something. This is genetically heritable disease. If there was nothing in the blood, it means it is a sporadic. If it is a sporadic, there's nothing more we need to do as screening purposes, because if it is sporadic, it is not heritable and it is not inherited. So there's no risk for the family members to have the disease. Now, if there was germline disease in the blood, we look at the blood of the parents, the father and the mother. If we find one of them harboring the same mutation, it means this is inherited from that part of the family. If there is none, it means it is not inherited. Heritable, but not inherited. I mean, it didn't come from any of the parents, but it can be transmitted to the next generation. So if that was not inherited, I don't need to do screening for the siblings. If that was inherited, I have to do screening for the siblings as well. Now, what is the benefit of doing enucleation? Mainly in unilateral cases, if we have tumor cells, this will give us more volume of DNA that is mutated, so we can look at the tumor itself to look for what are the mutations in the tumor. Then we look at the blood to check if these mutations exist or not. But in general, our direction is the blood and not the tumor cells.
Oh, excellent. That looks different. Right.
Totally different than what we do.
Yes.
Yeah.
Of course, there's a question / comment from Professor Copeland. It's in regard, like, I think, to more to educational programs, like kind of awareness things, you know,
Yes.
happening in the Middle East. I'm not really aware, but maybe Mesa, because you guys are in cancer centers, so yeah.
I will also direct this question to Yaqub, because he's very active in this regard, and perhaps he can summarize our experience at KHCC shortly from the very start until to the stage where we are now. Yaqub.
Yes, actually in Jordan, we treat patients from many of the Arab countries in the Middle East. Now, we started this service in 2003, before which the outcome for retinoblastoma in Jordan was very bad. Then we established one center, which is King Hussein Cancer Center, to treat all cases of retinoblastoma in Jordan. So we followed the strategy of centralized care to collect all the patients in one place. And by that, later on, we started to collect patients from the area, because there's very, very few specialized centers in the Middle East who are treating retinoblastoma. So we are treating retinoblastoma patients from around 14 different countries in the region. Now, this improved the outcome simply for number one reason, that even ophthalmologists now, they know where to send the patients. Because in the past, the ophthalmologist has no idea what to do for retinoblastoma patients, and there's no place that is taking care of these children. So we started to collect all these patients. So we improved the outcome just by having centralization of the care. The mortality for retinoblastoma decreased from 40% to 5%, and the eye globe salvage rate increased from 0 to 70%. So this was good improvement at this level. Now we started to look at the reasons why there is significant delay in starting treatment. One of the reasons we were surprised to have it that the first contact physicians were not aware of the signs for retinoblastoma. So there was significant delay due to lack of awareness among the first contact physicians, basically the pediatricians and the ophthalmologists. We did a study for that, and then we asked the medical schools to change the syllabus in their education system for the medical students to increase the awareness for the first contact physicians in the future about how to deal with patients with leukocoria or strabismus or something like that, mainly the pediatricians. And that improved part of it. The second part, because in our area, sometimes the family has more than one kid with retinoblastoma, we found that the outcome management for the second, third, and fourth children in the same family with retinoblastoma is significantly better than the proband, simply because the family started to know that there's something called retinoblastoma. So once they notice something in the family, they take it more seriously. They look for medical care immediately, so there's no delay. Now we are using the media a lot, the TV, the channels in the country. Every now and then we are giving new YouTube videos that educating the people about what does it mean leukocoria. Leukocoria, which is water pupil, it is something that is not normal. You have to look for ophthalmologist to look at the back of the eye immediately to rule out the possibility of cancer. The community started to understand that there's something called eye cancer, and this eye cancer, it may affect children because many of the people, they have no idea that there's cancer that is affecting the eye. So these are the three different strategies that we followed over the past 10 years to improve to enhance early diagnosis, early treatment, and better outcomes.
Okay, so we've got the last minute before we go to a coffee break, and that will be answered quickly by whomever, Sarah or Mesa. So how many grade categories are there for retinoblastoma, and is anaplasia a determinant of a G4 disease?
Sarah, would you like to answer this one?
No, I'll leave it to you. You showed the lovely images.
Thank you very much. So there are 4 grades. So grade 1 is usually the well-differentiated tumors that we showing lots of the florets, the bouquet of flower-like kind of rosettes, and usually this is associated with what we call the benign counterpart of retinoblastoma, which is retinocytoma, which is again something that is very interesting in terms of the biology. And then we have a grade 2 in which we have the 2 types of rosettes, the Homer-Wright as well as the Flexner-Winterstein rosettes, composing more than 50% or more of the tumor. Of course, we might have some solid areas, but then we have the rosettes composing 50% and more of the tumor for a grade 2. Grade 3, in which we have some rosettes that are present, but they compose less than 50% of the tumor. And a grade 4 is where usually this is a pure solid growth pattern, and usually anaplasia, the severe type of anaplasia, the worrisome type of anaplasia associated with the solid growth pattern or with the grade 4 of the tumor.
Okay, good afternoon, everyone, and thank you for being here. In this session, we will be discussing intraocular melanocytic tumors. Our first speaker is Dr. Mona Muhammad. Dr. Mona is a consultant ocular oncologist at King Hussein Cancer Center. She completed 2 fellowships at Moorfields Eye Hospital, London, UK, in ocular oncology and eyelid orbital tumors. She has more than 20 published articles in the field of ocular oncology, and she authored 1 chapter in a textbook. Dr. Mona is going to will be talk about clinical aspects of intraocular melanocytic tumors.
Thank you, Dr. It's my pleasure to meet you all today. and I will talk about clinical aspects of intraocular melanocytic tumors, and the main focus of my talk will be about choroidal melanoma. Choroidal melanoma is part of uveal melanoma, and this is the most common primary intraocular tumor in adults. As we all know that the uveal tract includes the iris and ciliary body and the choroid, and melanoma affects the choroid in more than 90% of cases, followed by the ciliary body tumors, and the least is iris melanoma. We divide choroidal melanomas into small, medium, and large tumors based on the thickness of the tumor as we measure by ocular B-scan ultrasonography. And roughly speaking, the 5-year risk of metastasis is related to the thickness of the tumor, where it is 16% for small tumors, and this rises to more than 50% for large tumors. So roughly speaking, each increase in thickness by 1 millimeter means 5% higher risk of metastasis. Unfortunately, metastatic uveal melanoma is almost always fatal, and it's very important to diagnose the tumor at an early stage before it metastasizes to improve patient survival. So early detection is important and has an impact on patient life. Risk factors for melanoma, it's more common in Caucasian people. The average age at diagnosis is 60 years. Patients with oculodermal melanocytosis or nevus of Otta, where it is a congenital condition where patients have melanocytosis affecting the ophthalmic and maxillary divisions of the trigeminal nerves. So for those patients, the risk of having a uveal melanoma is 1 in 400%. For patients with choroidal nevi, the risk of transformation into melanoma is roughly 1 in 8,000 cases. Today, we will present a case of ocular melanocytosis that had an intraocular melanoma and ended up by inoculation. The disease is usually asymptomatic, but sometimes if the tumor is affecting the macula or is happening around the optic nerve, then patients will have symptoms of visual loss, metamorphopsia, flashing light, or floaters. Sometimes patient presents with secondary effects related to the tumor because they have cataract, glaucoma, retinal detachment, or vitreous hemorrhage. And sometimes in advanced cases, patients will have eye pain related to severe intraocular inflammation or increase in intraocular pressure. Now, the diagnosis of uveal melanoma is mainly clinical, so we rely on examining the fundus using dilating eye drops and the untitled ophthalmoscope, as we can see here, and we support our diagnosis by ancillary tests, and the most common test that we use is ocular B-scan ultrasonography. So the diagnosis can be reached by clinical exam in more than 95% of cases. Just a reminder, this is the normal fundus, as we can see by indirect ophthalmoscope. This is the normal optic discs, and this is the retinal vasculature, and here we can see the fovea with the macula with the center in the fovea. So this is the normal fundus, but we can see here there is a melanotic tumor inside the retina associated with orange pigment lipofuscins, as we can see here, and with 3D examination we can find that this tumor is associated with subretinal fluid. These features are very characteristics of a choroidal melanoma. So melanoma most equals orange pigment plus subretinal fluid and thickness more than 2 millimeters. The tumor is mainly melanotic in more than 50% of cases. Sometimes in 30% of cases, the tumor may have amelanotic and melanotic parts, and the diagnosis is challenged in 15% of cases where the tumor can be totally amelanotic. Regarding the shape of the tumor, the most common shape is dome-shaped tumor, as we can see here, but sometimes there is a pathognomonic mushroom-shaped melanoma where the tumor breaks through the Bruch's membrane and herniates into the retina, causing mushroom-shaped melanoma or color stud appearance. Rarely, the tumor may have a flat, diffuse growth. But sometimes the patient may have exudative retinal detachment, and the mass may be hidden just underneath the detachment. So whenever there is exudative retinal detachment, there is underlying choroidal melanoma until proven otherwise. And for those cases, we have to do a B-scan ultrasonography to help us in seeing the underneath tumor. Now, Shields et al. Created acronym to differentiate between nevus versus melanoma, and it is TFSOM to find small ocular melanoma, where T stands for thickness more than 2 mm, F the presence of subretinal fluid, S symptoms of flashing and floaters, O orange pigment, M margin less than 3 mm to the optic discs. So patients with no risk factors are classified as low-risk patients, and they are monitored twice yearly and then annually, while patients with 2 risk factors have moderate risk and they need more closer follow-up, and patients with 3 or more risk factors, they have 50% risk to have melanoma, and they should be referred to experienced oncology center for opinion. Another addition to the TFSOM is UHHD, where UH stands for ultrasound hollowness, which is a feature of choroidal melanoma, as we will see later by ocular B-scan. H, absence of halo, and halo is a area of depigmentation that surrounds a lesion. So when we see this halo around the tumor, it indicates chronicity, and it is in favor of having nevus rather than melanoma. Same here for drusen. Drusen indicates chronicity, and the presence of drusen, they are suggested that this lesion is chronic and benign nevus rather than being an aggressive melanoma. D'Amato et al. Created another acronym which is called MOLES to help us to differentiate nevus versus melanoma, where M stands for mushroom shape, O orange pigment, L large size, E enlarging tumor, and S the presence of subretinal fluid. So these features help us to categorize our lesion, whether it is a benign nevus or an aggressive melanoma that mandates treatment by ocular oncology specialists. Now, as I said, the diagnosis is mainly clinical, but we rely on ancillary tests to support our diagnosis. And the most important is ultrasonography, which is a non-invasive modality that helps in seeing the tumor. We use a special probe, and we just apply gel on the surface of the eye. And different tumors, they have different acoustic characteristics based on the intraocular composition of the tumors. So this is the normal ocular B-scan. This is the front of the eye, and this is the back, where we can see the optic nerve and the flat retina with clear vitreous, and here we can see the anterior lens. But here we can see that with this B-scan in the middle, we can see a dome-shaped intraocular mass of low internal reflectivity, characteristics of uveal melanoma. This is another a choroidal melanoma with a pathognomonic collar stud or mushroom-shaped tumor with associated retinal detachment. So as I said, with ultrasonography, we can see the characteristic dome-shaped tumor of low internal reflectivity, which is also delineated here on a scan, and the presence of subretinal fluid associated with the tumor. Another B-scan showing the characteristic collar stud appearance or mushroom-shaped tumor with associated retinal detachment. Another tool is optical coherence tomography, which is a map of retinal layers. We can see here the normal foveal depression and different retinal layers. So this is the normal appearance of the retina by OCT. And here we can see a deep mass pushing the retina, causing shaggy photoreceptors and the presence of subretinal fluid, a characteristic of a choroidal melanoma. This is an OCT for a nevus versus melanoma, and we can see that the nevus is innocent, it's dry, it's not causing any fluid, while melanoma is causing the presence of subretinal fluid. Another tool is Fungus Autofluorescence, and this is important to show us the orange pigment lipofuscins, which characteristically they shine without injecting any dye. So this is the Fundus Autofluorescent photo. We can see the hyper autofluorescent spots indicates the presence of orange pigment lipofuscins. So to summarize what I have said, this is the back of the eye where you can see a melanocytic tumor with orange pigment lipofuscins, which are characteristically hyper-autofluorescence on fundus autofluorescent images. And this is the OCT showing that there is associated subretinal fluid, and the typical B scan showing a dome-shaped tumor with subretinal fluid. So the diagnosis of melanoma is mainly clinical, supported by different ancillary tests. The role of radiology scans like CT or MRI is limited because they are replaced by the B scan, which is a non-invasive and free of radiation. But sometimes we use the CT or MRI for larger tumors to make sure that there is no extraocular extension. This is the appearance of the tumor by MRI. This is an MRI scan axial cut, and this is T1 because the vitreous is black. This is the left eye. We can see a hyper-intense tumor on T1 and hypo-intense on T2, characteristic of uveal melanoma. So once we diagnose the tumor, we have to treat the patient, and in oncology we follow the pyramid where the first priority for us is to save the patient life, followed by saving the eye, and the least priority is to save vision. So when we read about treatment of uveal melanoma, there are different treatment modalities. I'm trying here to simplify the treatments that we use. So mainly we use either radiotherapy, and the most common form is plaque brachytherapy, or surgery, and the most common surgery that we perform is inoculation. So a plaque is a device. It's a circular device containing inside it a radioactive source. We use different radioactive sources, and the device is usually made of gold to act as a shield to prevent the backscatter of radiation. So this device, we suture it on the sclera just at the site of the tumor, and the target is to deliver the radiation dose to the intraocular tumor. So this is intraoperative images where we use the retroillumination to define the tumor, and we mark the surface of the tumor on the sclera, and then we insert and suture the plaque to cover the tumor with safety margin. This plaque is left in place for on average 3 to 5 days, and then we take it out, and the radiation effect continues on the tumor. The other forms of radiation is teletherapy. Tele, it means that the source of radiation is far away from the eye, and the most common forms is proton beam radiotherapy or stereotactic radiotherapy, but these forms of radiation are expensive and they are not available in all centers. As I said, the surgery is mainly inoculation. If the tumor is large and beyond the capacity of radiation, then we take the whole globe out and send it for histopathological examination. Or if there is associated neovascular glaucoma or a lot of retinal detachment or vitreous hemorrhage, so we take the whole globe out. So this is a large tumor beyond the capacity of radiation. We performed inoculation, and this is the eye just at the time of growth. At the time of inoculation, we put an intraocular implant to act as volume augmentation, and after wound healing completes, usually after 6 to 8 weeks, the patients are referred to ocularists to have artificial prosthetic eyes. Patients with uveal melanoma should be followed lifelong to check for local recurrence or distant metastasis, and the most common site of metastasis of uveal melanoma is to the liver, so the patients should have routine screening to check for liver metastasis. This slide shows Fundus photos for tumors before and after treatment. So the top images shows the tumors before treatment, and the bottom shows the tumors after treatment. On the left, the tumor is darker, associated with orange pigment lipofuscins, and the bottom photo shows that the tumors after treatment becomes much darker, flatter, and there is less of active orange pigment diffuses. Similar to the right, the tumors on the bottom becomes more dark, flatter, and has less intrinsic vascularity, indicating that the tumor is well treated as and inactive. By this, I finish my presentation. I tried to simplify my talk, and I hope that you enjoyed it. Thank you for your listening.
Thank you very much, Dr. Mona, for this very excellent presentation. And now we will keep the questions at the end of the cases, and we will move to our second speaker, Dr. Jacob Zeus. Dr. Jacob is a consultant of pathology and eye pathology at King Hussein Cancer Center. He has his MBBS degree from University of Jordan in 2005, and he did his histopathology training at King Hussein Cancer Center and King Abdullah University Hospital from 2007 to 2011. He completed his fellowship in surgical pathology from 2011 to 2013 at King Hussein Cancer Center, and in 2018 and 19, he joined Professor Sarah Copeland in Liverpool for 1-year fellowship in ophthalmic pathology, sponsored by Eye Cancer Foundation. Dr. Jacob co-edited 3 chapters in eye pathology books and published several papers. Dr. Jacob will be talking about pathology of intraocular melanocytic tumors. Dr. Jacob, are you ready?
Yes, thank you very much, Iman, for the nice introduction. I would like to thank the organizers for inviting me, and thank you, Mona, for the nice lecture. Today, I would like to share the slides first. Okay, wait a second, share screen. This one. Okay, can you see my lecture now?
Still, it's in process, but not yet.
Yet?
Not yet.
Not yet.
It says you are screen sharing.
Yeah.
Yes, it's working.
Okay, so it's now full screen, should be. Okay, thank you, Mona, for introducing the...
Please press full screen again, Dr. Jacob. It's not full screen.
It's not. Is it now full screen?
No, no.
Not yet?
Yes.
It's full screen here. Okay, I will try again.
Okay.
You can stop sharing and redo it again.
Yeah, I will. Yeah. Okay. Stop. Is it now full screen?
No, not yet.
Not yet.
No.
Ah.
I think if you stop sharing and then restart sharing, but share your whole screen rather than just the presentation.
Okay, so yeah, how do I stop the sharing?
At the top.
Yeah, from the
من السهم.
Yeah.
من السهم وبعدين right click.
I'll come to you.
Okay, sorry for that because I don't have a stop sharing.
I can do it actually.
ليش مش هي؟
Yeah, is it now full screen?
Yes.
Okay. Yeah. Is it moving? Yes. Is it moving?
Yes, yes, you may.
Okay. Thank you, Maisa. So I need a little help. Thank you, Mona, for your speak about the choroidal melanoma. Actually, I will not cover the whole topic about intraocular melanocytic lesions. I will talk about the histopathology of uveal melanoma and the approach, how to gross and how to do a histopathologic reporting. First of all, you are familiar of this new edition of the WHO Blue Book of Eye Tumors. So the uvea is composed of the iris, ciliary body, and the choroid, and this is a long list of tumors involving the uvea. Fortunately, not all lesions are seen at the histopathology department. Most of these lesions are diagnosed clinically and treated clinically. Unfortunately, uveal melanoma is a common disease in Western population. Fortunately, it is less common in Jordan and treated medically before reaching a large tumor size where it needs to be treated by inoculation. So in reporting uveal melanoma, there are many guidelines that makes your life easy. So the Royal College of Pathologists, I know this is not the recent one, but I know that they publish guidelines, dataset to report and to how to gross and gross the inoculation and other samples of uvea of intraocular tumors. The College of American Pathologists is the one that I use here at King Hussein Cancer Center. I follow up the guidelines in reporting. So this is my data set. First thing, the story starts from the surgeon. This is a freshly inoculated eye done by Muna before sending it to the lab. So the surgeon, the ophthalmologist, do his job with and he measures or she measures the optic nerve. She or he put a mark where it can help me in orientation to orient the sample. It can be sent fresh, and in our hospital I do it in formalin. So this sample is sent in a cup full of formalin 10:1 for a fixation time of 24 to 48 hours. There is no need to do any incision or to do any cut. It is left in formalin for 24 hours for fixation before handling it. So in other hospitals where cytogenetics are used and tissue banking is available, fresh samples can be sent to the lab and the sample can be evaluated in fresh status, then fixed in formalin. So in the lab, this is a photo of me in Liverpool and doing the grossing of the eye. This was a fresh sample. The first thing is to take measurements. So it's important to take the 3 measurements of the eye globe: AP diameter, horizontal and vertical, optic nerve length, and optic nerve diameter, in addition to cornea measurements. As Maisa said previously, orientation of the sample is important. So we should know the exact anatomy of the eye globe. So we should know the forerecti muscle, the superior, inferior, medial, and lateral rectus. These are the main 4 muscles, and the other 2 muscles are the superior oblique and the inferior oblique muscle. This view is from the posterior, and for my guidance, the surgeon, the ophthalmologist, kindly put an ink on the medial rectus muscle. This makes my life easy and make an error less likely. However, if you receive a sample without this mark, you can, as Maisa said previously, you can orient the sample by looking just at the superior oblique muscle, where it is inserted in the eye temporally or laterally, and the fibers are going nasally. Again, you can make use of the optic nerve and the vessels. So this is one of the cases that we have received in our lab. I will use the mouse here. You can see there is an area of pigmentation here, and there is a muscle there. Going into higher power, you can see grossly a tumor anteriorly, and you can see here the blue ink put by the surgeon. So it is exactly on the medial side of the eye. You can make use also the other marks like the optic nerve. You look for the ciliary, for the vessels here, and definitely you need to look for the vortex vein. Vortex veins is something that is different from the retinoblastoma. You don't sample vortex vein in the retinoblastoma, but in uveal melanoma, you need to sample it. In advanced tumor, it becomes swollen and darkly pigmented. So after orienting the specimen, an important part is to do the transillumination and the marking. So this is a textbook photo where you can see, you need to have somebody in the room and ask him gently to turn off the lights, because if it is a gross room with multiple people working in it, it will be, you need to ask for permission. So you need a really dark room and transillumination and to do a marking. So this is an anterior tumor and heavily pigmented. Based on this, the next step depends on the location of the tumor and the size of it. So it's not the, it depends how do you cut it. If you cut it vertically, horizontally, or obliquely, it depends on the location of the tumor. It's preferred that you have the full thickness of the tumor in the PO section. So we have the PO section and again 2 calots. It's not necessarily that we have superior and inferior. We might have medial, lateral, and even oblique calots. So this is the same case where I have this tumor here medially. So I do horizontal cross section from medial to lateral, and I will end up having a superior calot and an inferior calot. This PO section will be important in measurement of the tumor and looking for the high-risk features. In comparison to retinoblastoma, there is low risk of optic nerve invasion in uveal melanoma. However, I still do the cut-end margin of the optic nerve and the sampling of the vortex vein before cutting the sample. So this is after cutting the horizontal section, we will have one of the calots, the PO section, and before cutting the second calot, I examine it from inside, sometimes using the torch. In this case, you can see the retina pushed by a tumor, a big tumor here, and causing extension posteriorly. You can see the tumor is extending anteriorly. So by gross examination, it is important to look for high-risk features in a choroidal melanoma, those including the anterior part involvement, posterior involvement, extrascleral or extension, and the size of it. So these are 4 poor features regarding the prognosis. Measurement of the tumor is done, I do it clinically, histopathologically. So by doing 2 measurements, according to this study, collaborative ocular melanoma study, they classified uveal melanoma into 3 parts, according to the size: large tumor, medium tumor, small tumor. Mona said different measurement in her according to imaging. According to collaborative ocular melanoma study, we have those 3 categories with a 10 millimeter height, making it a larger tumor, or if you have a basal diameter greater than 16 millimeter, it is a larger tumor. Anything less than 10 millimeter and less than 16 millimeter is considered the medium, and it should be more than 2.5 millimeter. Small tumors are less likely encountered in our practice because they are managed clinically before and not necessitating the enucleation. Okay, the AJCC cancer staging manual has different categories, T1, T2, T3, and T4, based on the largest basal diameter and thickness. Okay, so while I'm using TNM staging, I use the AGCC cancer staging manual. As I said, I use the light to look for anterior, posterior, and extrascleral extension, and to sample the areas with suspicion, extraocular extension. So it's not like retinoblastoma where I need to bread loaf the calots. Sometimes I end up by 2 PO section. It depends where I can find an extraocular tumor. This is somebody asked about text box in Pathology in the chat. I will mention 3 or 4 Pathology books because I needed to borrow some photos. Yeah, so first thing, we need to stratify the tumor based on the size, on the location, and on the growth pattern and pigmentation. Many of our tumors are hyperpigmented. As Mona said, more than 50% are heavily pigmented tumor. Most of the tumor we have in inoculation sample are larger tumor. Small tumor are usually treated clinically. So uveal melanoma or choroidal melanoma can be small. Small tumors are usually located posteriorly because they are detected earlier, since posteriorly can vision be affected very early in the disease. Anterior tumor usually grow large in size because they are hidden behind the ciliary body, and loss of vision happens very late in the disease process. Some of the small tumors are usually dome-shaped, while large tumor will mostly have this characteristic mushroom-shaped tumor. And this is an equatorial tumor, large tumor showing a mushroom shaped where you have a break here in Bruch's membrane and the tumor is growing into the retina. This is one of our cases where you can see a semi-mushroom shaped tumor where you can see one of the areas here growing like a mushroom shape. You can see that this tumor is large with extensive retinal detachment, this exudative pink retinal detachment. Microscopically, this is the retinal pigmented epithelium. Underneath is the Bruch's membrane, which separates the choroid from the retina. And at one point, when you follow the Bruch's membrane, you end up seeing a break or discontinuity, and this is reflected in the same photo at this point. You can see also melanophages going into the exudative retinal detachment. This is the tumor breaking through Bruch's membrane and the retinal pigmented epithelium, causing retinal detachment. And this is what Mona said previously. I need to remove this. Okay, this is what Mona said, the orange pigment. The orange pigment clinically is reflected histopathologically in the form of melanophages or macrophages in the subretinal fluid or in the retinal detachment, where they ingest the lipofuscin pigment from the retinal pigmented epithelium and melanin. So it indicates a break in the Bruch's membrane, a break in retinal pigmented epithelium, and the tumor extension into the retina. This is one of the points important in differentiating small tumors from nevi. Okay, this is the orange pigment clinically, radiologically, and this is by histopathology. Again, this is another case, a large tumor. The next step in examining the tumor is looking for the high-risk involvement of anterior structures here, and extension into the posterior. So this is the PO section, this is the optic nerve, the lens, the cornea, and this is the angle. This is a tumor, a large tumor. It looks like pushing the ciliary body and reaching the lens posteriorly. Definitely it looks abnormal. The sclera here looks abnormal with the tumor infiltrating into the sclera. And we should thoroughly examine this area, the anterior or the angle part. So this is the uninvolved angle, where you can see the root of the iris, the ciliary body, the sclera, part of the cornea, and you can see the Schlemm's canal and the trabecular meshwork. Sometimes you need multiple deeper levels to examine this area because it reflects a poor prognosis for that patient. This is a huge tumor involving the ciliary body. You can see the ciliary body pushed. The root of the iris is free of tumor, but you can see the tumor here is splaying or going in anteriorly. You can see the Schlemm's canal here, but if you go into deeper level, and you notice the trabecular meshwork, it's not only pigment there, but also you can notice tumor cells producing pigment. It's important to be sure that these are tumor cells, not melanophages. So sometimes you need to do immunostains. I prefer the nuclear one, SOX10. And if it is heavily pigmented, you need to treat it by special techniques. The other thing is to look for the exit ways. As Sarah mentioned it before, the exit ways are the vessels that are seen anteriorly and posteriorly in the sclera. So these are the vessels where you can see the nerve, the arteriole, and the venule. These are usual exit ways of a tumor outside the sclera. Sometimes the tumor may be missed just by not doing deeper level or not paying attention to those small vessels. So this is one of the tumor anteriorly. So this is a ciliary body. You can see pushed by this heavily pigmented tumor, and you can see the ciliary body involved by tumor. This is one of the cases Mona will present later. And you can see tumor cell here. It's anteriorly one of the vessel, and it is pigment. You can see pigment around the vessel, and you can see some pigment outside it. So this is one of the cases Mona will present. Going into the higher power, you will see the pigment and tumor cells around the vessel. Another case where you can see a small vessel with perivascular tumor, and these are small, this is the vein, and these are the small neurons where you can see perineural invasion. Sometimes these small cells end up by making a huge mass. For example, this is posteriorly. You can see the optic nerve. These are the exit point posteriorly, venule, arteriole, and neuron. You can see the tumor skipping some areas, going around the vessels. If you go at high power here, you can see single cell. I used immunostain. I don't have a photo now, but definitely there was some scattered tumor cells outside. Some tumors grow diffusely in the choroid, and you can see pushing into the optic nerve. Again, you can see some capillaries involved by tumor here and a perivascular tumor there. So this is important in to do multiple deeper levels in order to detect these cells. This is a textbook photo. Fortunately, I don't have any of those cases until now. This is a huge tumor that recurred in the peripapillary area outside the eye. This is the swollen, dark vortex vein. You can see lymphovascular invasion. This is a huge tumor also growing outside the eye anteriorly into the conjunctiva. And this is a tumor here growing into the optic nerve. So this is diffuse choroidal melanoma here, growing into the optic nerve and making an extraocular mass. Fortunately, until now, I don't have devastating similar case. So by ending up of the extent of the tumor, we need to go and to tell what are the cytomorphology of this tumor. It is well known that uveal melanoma or choroidal melanoma specifically has 3 cell types according to the AGCC cancer staging. It is graded into grade 1, 2, and 3. Spindle cell melanoma has more than 90% spindle cells. Mixed cell melanoma is a mixture with more than 10% epithelioid and less than 90% spindle cells. Epithelioid cell melanoma has more than 90% of epithelioid cells. It is important to look for epithelioid cells. Epithelioid cells carries a poor prognosis for patients with uveal melanoma. Spindle cell melanoma in reverse have the most favorable prognosis in comparison to epithelioid. So that's why there is an alternative histopathological grading, just to tell that this is a spindle cell melanoma or non-spindle cell melanoma. Non-spindle cell melanoma, where you can see any percentage of epithelioid cells detected, are put into this category. This is the histopathology of both, the cytology of both epithelioid and spindle cell melanoma. It is well known in the textbook that the modified calendar classification that we have spindle A, spindle B, and epithelioid in addition to the mixed. Spindle A melanoma, these are slender, small spindle cells with no prominent nucleoli. This is usually seen in nevi as a pure form. The spindle B, they are more oval in shape. They have small nucleoli in comparison to spindle A. Epithelioid cell melanoma are large tumor cells with abundant cytoplasm, larger nucleus, and prominent, sometimes red nucleolus. Mixed cell melanoma, it can be seen adjacent to each other, or you need to look at different areas in the same slide, or on different slides. Sometimes when it is heavily pigmented tumor, it would be difficult to categorize this. So you need to bleach the slide or to go to less pigmented areas. Epithelioid cell melanoma sometimes become binucleated, having prominent nucleoli, well-defined cell border, abundant eosinophilic cytoplasm. You can encounter also less or smaller in size epithelioid cells, where you can still have the nucleolus, but the cells are smaller, round, and less abundant cytoplasm. This is still considered an epithelioid type. Epithelioid melanoma sometimes contain bizarre cells with inclusion-like nucleoli, red inclusion, cytoplasmic inclusions, sometimes binucleated cells resembling RS cells. Anaplasia is commonly seen in melanoma. It's just a histomorphology or cytomorphology feature. It's not a specific subtype. It can be diffuse, but sometimes you need an amelanotic lesion to do special stains to be sure that this is melanoma. Balloon cell change is a common change also, where you can have a clear cytoplasm inside the tumor cells. This is very nice inclusion at the edge of this slide. So it is a morphologic subtype of epithelioid melanoma. Spindle cell melanoma, it carries better prognosis, where you have a spindle cell, there are no cell borders, small nucleoli, and it's but usually you should look for epithelioid cells. Personally, I always find epithelioid cells in all tumors. So
Dr.
this is
Dr. Jacob, I'm sorry, you have 5 minutes left.
yeah, I will finish. Okay, so this is to summarize, this is a textbook photo from old fascicular melanoma. Mitosis is common. Mitosis is also a poor prognostic feature in uveal melanoma, including the atypical mitosis here. Necrosis, if tumor gets large in size, the tumor will lose its vascular supply and get necrosis. So it's associated with larger tumor size. That's why it is associated with poor prognosis. Another thing to look is this photo is taken from the eye pathology. I think this is for the photo taken by Sarah previously. And thank you, Sarah. And this is one of my cases where you should imagine the vascular loop. So this is a textbook photo where you can see a full circumferential vascular loops. Vascular loops and vascular lakes, this is one of my cases, are associated with poor outcome. This is one of our cases where you can see vascular leaks and some sort of papillary configuration. Tumor infiltrating lymphocytes and tumor infiltrating macrophages are also associated with poor outcome. So what I do is to give a diagnosis, to be sure that this is a uveal melanoma, and then we need to do to report according to the data set the poor prognostic factors that I have mentioned in my lecture. The other thing that I unfortunately not doing it yet is the molecular and the cytogenetic test. This is the new edition of the WHO book, and this photo is taken from this book. BAP1 immunostain, it reflects the chromosome 3 status, where when it is lost, it's associated with poor prognosis and high risk of liver, not only liver and extraorbital metastasis. So by doing a BAP1 stain or doing the cytogenetic test, FISH, for example, we look for the chromosome 3 and other chromosomes to look for poor cytogenetics, and there is also molecular classification of the uveal melanoma. I'm not going into the molecular details, where you classify a high-risk tumor and a low-risk tumor. But BAP1 stain is good for prognosis. When it is lost, it means that the tumor has a high risk for liver metastasis. You know that uveal melanoma spread after a couple of years outside the orbit, and that's why we do the all prognostic classification to detect which patient is needs to be followed up, and because once metastasized to the liver, to the lung, unfortunately the patient will deteriorate quickly. Finally, I would like to thank the organizers for this lecture. I would like Dr. Amaisa, Dr. Omar, Iman for introducing me, Mona for the talk. In this photo, definitely Dr. Ismail Matalqa, Maher Zghayar, for giving me the opportunity to train in pathology. Yaqub, thank you very much for introducing me to Professor Paul Finger. Paul Finger, thank you for sponsoring me. Sarah Copeland, it's every thanks to you for hosting me in Liverpool for 1 year and giving me the opportunity to give melanoma, and which is in your field, the melanoma topic. Thank you very much, Sarah, for everything, and thank you everybody for listening.
Thank you very much, Dr. Jacob, for this very informative and excellent lecture. And now for the next 30 minutes, both Dr. Mona and Dr. Jacob will be sharing with us some interesting cases on the topic of intraocular melanocytic tumors.
I will share the photos.
Okay.
You should give me the share back.
Just press on share screen.
Yeah, just I will share the.
Okay.
Just a second. Okay. Hopefully I will do it right this time.
Inshallah. Okay, it's not full screen yet.
Again?
Yes.
Okay. Okay, I will. Is it?
No, not yet.
No, I have a problem with that.
Dr. Jacob, if you press F5, I think on
Okay. Okay.
Right. Okay. Can you press on the little like cup shape at the bottom?
Actually, I pressed it. It should be now full screen.
It's not yet.
It's not.
Wait. I know what's the problem. Are you seeing it as full screen in yours?
Yes.
Okay. Now just press escape on the full screen.
Okay.
And go back to this. Okay, and now go back to Zoom.
To Zoom. Okay. Yeah.
Okay. And share screen.
Okay, I'm going to Zoom. Problem with that. I will stop sharing. Maisa will come. Maisa will help me again.
No,
okay.
no, you have all the privileges. I'm the host now, so.
Yeah, Maisa will help me. She's coming. She has next office next to me. Yeah.
Stop sharing.
Okay, stop sharing.
Okay, وين احنا؟ اوكي وين هذا؟
هي صورته. This one. Is it full screen?
No.
No?
No, not yet.
Oh, really?
Now? No, it's not.
Not yet.
I think you are sharing the wrong screen, guys. You know, because.
Okay. Wait a second. We did it last time. This one?
Yeah.
F5.
Yes.
طيب هون. Okay. And then مستحيل to share full screen. How did we do it last time?
Dr. Muna, can you share from your side?
Okay, I will try now.
Marie, we have to stop sharing. F5.
Nice.
Oh, this is so unusual. Oh, does she have it on the presentation?
Yes. Okay. Okay, Muna, you will share it?
I'm trying, yes, to share. I have it full screen now. Do you have
it full screen?
Okay.
It is full screen.
Sorted.
Okay, so now we will present our clinical and pathological melanoma cases, and I will start with the first case. This is a 60-year-old female with a free medical history. She noticed right eye painless, gradual loss of vision over the last 8 months. On examination, her visual acuity for the right eye was query light perception, and for the left eye was 6.6. Now, upon examination, as we can see here, this is the conjunctiva, and this is what we call the sentinel blood vessel. Now, the sentinel blood vessel is a blood vessel that supplies an intraocular tumor, and also she had a dense cataract. Actually, behind the cataract, it was very difficult to visualize, but I could detect that there is an intraocular mass, mainly suited at the ciliary body, and it was pushing the iris at the site of the mass and causing shallow anterior chamber with focal angle invasion and iris atrophy. Actually, the anterior segment photos are not clear, but I'm describing what I have seen clinically. Also associated with the mass, she had an exudative retinal detachment. So as I said in my lecture, whenever we have a suspicious of an intraocular tumor, the next step is to do ocular B-scan ultrasound. And this is her B-scan where we can see a large dome-shaped mass. We measure the mass. We measure both thickness and basal dimension of the tumor. And thickness was 14 millimeter in thickness and almost 19 millimeter in largest basal diameter. And it was associated with retinal detachment, as we can see here in the bottom of the image. Again, this is the MRI scan. This is the axial MRI. This is T1 because the vitreous is black. And we can see here on the right eye, there is an intraocular mass. It's hyper intense on T1. And the same mass is hypo intense on T2 and is associated with an retinal detachment. This is another view for the MRI. We can see the large mass suited anteriorly, pushing the anterior segment of the eye. And this is the T2 appearance of the mass with retinal detachment. So for those patients, once we have suspicious of intraocular tumor, we have to do staging scans to make sure that there is no distant metastasis. And the patient did a full body CT scan. It was free for metastasis. So our impression that this is a case of large size, right eye ciliochoroidal melanoma, and the tumor is large. The thickness is 14 millimeter, which is beyond the limits of radiotherapy. And therefore, the patient was listed for right eye inoculation and orbital implant. Now the mic is yours, Jacob.
Yeah, I will need your help to go.
Okay.
Okay, please, Mona. Okay, so this is case 1. You can see I have one of the slides I have previously showed. It's a large tumor involving the anteriorly into the ciliary body and involving the sclera. It is heavily pigmented. Posteriorly, the optic nerve is free. The photo on the right side, you can see the edges of the ciliary body and a large dome-shaped tumor with retinal detachment. Please, Mona. Going deeply, microscopically on the area pointed by a pointer, please, Mona. Look. Okay, so this is a tumor, pigmented tumor. It is a choroidal melanoma, where you can see it's replacing the choroid. You can see at the edge the retinal pigmented epithelium at 6 o'clock. The tumor is pushing into the sclera. The pink area is the sclera, and you can see there is a limit between the tumor and the sclera. But if we go into the next slide, please.
Okay.
If you go into high power and doing deeper level or looking at other slides, you can see single cells infiltrating into the sclera, where you have a scleral invasion by tumor cells. Next, please.
Okay.
Again, looking at the choroid and the retinal pigmented epithelium, you can see at the right or the left side of the image the usual choroid, pigmented choroid. Going into the right side, there is a growing heavily pigmented tumor breaking into the trying to break the Brooks membrane at 2 points. There is extensive retinal detachment at this point. Please, Mona. These are the blood vessels passing through the sclera and the choroid. These are the areas that we should look for extrascleral mets. Please, Mona. So going into the anterior part of this tumor, please, looking at the angle. Mona. This is the same tumor photo seen previously. The tumor is involving the ciliary body here. The tumor is also extending into the angle, where you can see pigmentation near the Schlemm's canal and near the root of the iris, but not invading the iris itself. Please, Mona. Again, this is at 12 o'clock, you can see part of the ciliary body. You can see part of the cornea with the Bowman's membrane and the sclera. You can see that the tumor is pushing anteriorly, the ciliary body pushing the lens, not in the photo, in other photo there was a lens pushing anteriorly. So the angle here is should be examined thoroughly. Please, Mona. This is the trabecular meshwork. As I said, this should be looked thoroughly, and based on this, there is anterior angle involvement. Please, Mona. Again, this is the tumor inside the trabecular meshwork. Mona. Posteriorly, grossly, the optic nerve was free, but still you see some pigmentation in the adjacent choroid, but by itself, the optic nerve is free of tumor. Please. These are the tumor cells with vague nodularity, forming focally vascular loops. Please, Mona. Just going to the type of the tumor, this is an epithelioid tumor where you can see an abundant eosinophilic cytoplasm. The nuclei in this part are small, but on the next slide, you can see larger nuclei, binucleated with prominent nucleoli and inclusion. This is a heavily pigmented, this is an epithelioid melanoma. Muna. Again, the same photo previously. Muna. So final diagnosis, this is a choroid melanoma epithelioid type, heavily pigmented, invading the ciliary body, the sclera, the trabecular meshwork. There is retinal detachment. There is a try to break the Brooks membrane, but it was not full break. Mitotic count is high, 25 per 40 high power fields. Focally, there were complete extravascular loops. Optic nerve free, no vascular invasion. Based on the size and the ciliary body involvement, this is T4B category. Thank you, Mona.
Thank you. Now, our next case is a 65-year-old female known to have diabetes and hypertension. She had painless drop of vision in the left eye over the last 1 year. On examination, her visual acuity for the right eye was normal and for the left eye was counting fingers. And this is the external photo for the patient. We can see that the skin overlying the eyelids, upper and lower eyelids, is hyperpigmented. And also we can see melanocytosis involving the sclera. I don't have photo to compare with the other eye, but if we compare the color of the iris, we will have an entity, we call it heterochromia iridis, in which the iris on the same side of the hyperpigmentation is darker. So we call it heterochromia. And this is the clinical diagnosis of ocular dermal melanocytosis, which I highlighted in my lecture. It's a congenital abnormality where patients have a pigmentation affecting the V1, V2 divisions of the trigeminal nerve. And patients with ocular dermal melanocytosis or nevus of Otto, they have higher risk to harbor intraocular uveal melanoma. So we can see here, just behind the lens, there is an amelanotic lesion. This is another photo for the mass, and this is the B-scan confirming the dome-shaped tumor with thickness of 13 millimeter. We performed orbital MRI as usual, and we didn't have any extraocular extension, and metastatic workup was free for metastasis. So the patient had the diagnosis of large choroidal melanoma beyond the limits of brachytherapy, and she was listed for left eye inoculation and orbital implant insertion. This is the specimen at the time of inoculation. We can see here the areas of hyperpigmentation indicating melanocytosis. And immediately at the time of inoculation, we measure the length of the optic nerve. The areas of melanocytosis are more clear here. Now the mic is yours, Jacob.
Yeah. Okay, so this is the gross photo of the same tumor, where you can see a large tumor and pigmentation of the sclera. This is a huge tumor with retinal detachment. You can see the 6 o'clock part is involving the anteriorly, trying to involve the ciliary body. This will be confirmed or need to be confirmed by microscope. Please, Mona. So this is a huge tumor. You can see the photo on the left side. It's involving the whole orbital, the cavity. You can see the retinal detachment, and it's one of the calots actually. On the right side, this is another calot. So most of the tumor is in the calot in this case. Please, Mona. So it's heavily pigmented tumor. This is the same photo, the ciliary body on the right side, pushed by and involved by heavily pigmented tumor. You can see the anterior vessels with perivascular involvement. The sclera itself shows heavy pigmentation. You can see the outer surface of the sclera shows heavy pigmentation. Mona. Again, this is the perivascular tumor. Please, Mona. This is the conjunctiva, part of the conjunctiva. You can see also the pigmentation in the subepithelium in the of the conjunctiva. This is not a tumor, it's only hyperpigmentation. Please, Mona. Again, there is diffuse choroidal pigmentation, and this is away from the tumor and shows diffuse choroid pigmentation and the scleral pigmentation. Una? Yeah, it's same. You can see the heavy pigmentation of the choroid, the sclera, and in the perivascular area. It was a challenge for me to look for the tumor cell. Actually, the first focus was easy. I did Soxten immune stain and it was positive. So, so it was detected the scleral invasion. Please, Mona. Vascular invasion. This is a heavily pigmented tumor. It's mostly epithelioid. Yes, please, Mona. So this is, as I said, if it is heavily pigmented, just look at the edges of the tumor. You will find those anaplastic large epithelioid cells with large inclusion in the nuclei and some binucleated cells. So this is the epithelioid part of the tumor. Please, Mona. These binucleated tumor cells again, and some prominent nucleoli. Yes, please. You can see the anaplastic cells as well. This is a small epithelioid component of the tumor. Again, you will find those less pigmented areas, and you can easily tell the subtype. Please, Mona. This is the spindle component of the tumor cell, where it's growing in a fascicular pattern, less prominent nucleoli, and no cell border. So this is a mixed type of epithelial of uveal melanoma. Please, Mona. And this is the loops where it's growing in some tumor areas. This is the high power view. There is thin capillaries around each cluster of tumor cells. Yes, please, Mona. So this is a mixed type epithelioid melanoma with 70% epithelioid cells, heavily pigmented. There is diffuse, in addition to the tumor, there is diffuse pigmentation of the choroid, sclera, and the conjunctiva. The mitotic count again is high. Anything above 5 is high. Focal extravascular loops are seen. And again, this is PT4B tumor. Thank you, Mona.
Thank you. So just to highlight, those patients, they have pigmentation affecting the sclera, but actually the risk of malignancy is in the choroid. So they are not at risk of conjunctival melanoma. The risk for those patients is to have more of uveal melanomas. Okay. So our last case is a 6-year-old girl, previously healthy. Her parents noticed left eye crossing of 4 months duration, and they bring her to us. On examination, her visual acuity for the right eye was normal, and the eye examination for the right eye was entirely normal, but the left eye vision was hand motion. And on examination, she had a retinal detachment with a large intraocular mass. So she had what we call a leukochuria, which is a white red reflex, as my colleague, Dr. Jacob Zeus, mentioned in his talk. So we couldn't have any view to the back of the eye. We performed a B-scan ultrasound, and we can see here there is a large intraocular mass occupying more than half of the globe. It is not associated with calcification, and calcifications are characteristics of retinoblastoma, which is a diagnosis that we put on top of our differential for such age group. But her tumor was lacking the calcification, and also with the mass there is associated retinal detachment. As I said, the other eye was entirely normal. We performed orbital MRI, and as we can see here on the top, we can see a large intraocular mass, which is hyper intense on T1, and it is filling half of the eye. Sorry. Filling half of the eye from anterior to posterior. And this is another axial view with the T2. We can see a hypo-intense lesion with retinal detachment. The mass was not associated with optic nerve or extraocular extension. And I will answer a question which Prof. Copeland asked during my presentation about whether we performed biopsy in cases where we don't have a diagnosis. Actually, during my practice at King Hussein Cancer Center, we didn't perform any diagnostic biopsy for our patients. For this girl, she had a large tumor, and our working diagnosis was medulloblastoma versus retinoblastoma versus malignant melanoma. And as I said in my talk, with a treatment of malignancy, we follow a pyramid where the first priority is to save the patient life. So such an eye with a large tumor, we know that the chance of a globe salvage and the chance of a vision salvage is very minimum. So if we tried with any treatment modality, we counsel the patients and their families that the risk to have a vision is very minimum. And our priority is to save the patient life first. So in such a case where we had a large tumor and we were just wondering whether this is retinoblastoma or medulloblastoma or melanoma. So after a thorough discussion with the patients and with the family, we decided to give 2 cycles of systemic chemotherapy as we do for cases of retinoblastoma, and follow the patient thoroughly to see if there is any response to treatment. Actually, after the first cycle of systemic chemotherapy, we examined the patient and we repeated the scans, and the tumor didn't show any response. It remained the same size, and we had the same size of retinal detachment, which is weird. In cases of retinoblastoma, usually there is at least 15% of shrinkage after the first cycle of chemotherapy, which was not the case here. And because we know that whatever we did for this patient, there is no chance to save the vision for such girl. So we discussed with thoroughly the case with the parents, and they agreed to proceed for inoculation. So we performed inoculation, and I will leave the mic to Dr. Jacob to give us the final diagnosis.
Okay, so we have a few photos regarding this case. Again, this is one of the tumor that I have shown previously. This is a dome-shaped or large tumor melanoma pushing the lens anteriorly. You can see how it takes the shape of the lens anteriorly. Posteriorly, it is causing retinal detachment. It is abutting, but not close, but not invading the optic nerve. So I did the gross as uveal melanoma case because once I opened it, it was heavily pigmented tumor. Next, please. So this tumor shows extensive retinal detachment. The arrow is showing the upper part of the tumor where there is extensive retinal detachment. Please, Mona. Anteriorly, the tumor is seen also pushing into the ciliary body and going into the less pigmented areas. It showed epithelioid morphology. Please, Mona. Again, this is the ciliary body anteriorly where you have tumor cells involving the pars plana of it. Please, Mona. This is the conjunctival part. Anteriorly, it's free of tumor. Please, Mona. The angle in this case was free. Please. And anteriorly, where you can see the tumor is attached to the lens and pushing it anteriorly. Please, Mona. And you can see the iris nearly touching the Bowman's layer of the cornea. So below is the cornea. You can see the center part of the iris and the lens nearly touching the cornea. Please, Mona. And this is posteriorly where you can see the optic nerve clear of tumor. These are the orange, the melanophages or macrophages inside the retinal exudate. Yes. And the vessels here are free of tumor. So this is epithelioid type, heavily pigmented choroidal melanoma with extensive retinal detachment. Mitotic count is low. Optic nerve is free, and other high-risk features are not seen. No extravascular loops, no vascular invasion, and again no tumor infiltrating lymphocytes. I did immune stain for this case because it was pediatric and it was positive. Thank you very much.
Okay, thank you.
Thank you very much, Dr. Mona and Dr. Jacob, for the interesting and very well presented cases. We have a few questions. directed for both of you. The first one is from Dr. Sarah Copeland. I think this one is directed to Dr. Mona. Do you perform the clinical TNM staging system for uveal melanomas?
Yes, yes, we do. We do the AGCT classification system, and actually, this is a system that contains TNM, T related to the thickness of the tumor, N for lymph node metastasis, and M for distant metastasis. And actually, according to a study that we are about to publish very soon, almost 50% of our cases were classified as T3. So T is based on the thickness of the tumor, as Dr. Jacob highlighted in his talk. So T1 is a tumor that have less thickness and less basal diameter. As we go up, the thickness of the tumor becomes higher and the basal dimension becomes wider. So most of our patients, 50% over the last year, were T3. And actually, it's very rare to have a distant metastasis at the time of diagnosis. So over the last 10 years, we had 2 cases who had a distant metastasis that was diagnosed at the time of having the initial diagnosis of choroidal melanoma.
Thank you, Dr. Mona. We have another question from Dr. Sarah, also to Dr. Mona. Do you perform any intraocular biopsies in cases where you are unsure whether it is a melanoma or another choroidal tumor, such as metastasis?
Okay, actually, as I said, the diagnosis is mainly clinical, and also Dr. Jacob in his talk about retinoblastoma highlighted that we as an ophthalmologist, we usually see the tumor and we are able to pick up certain clinical features that will help us to differentiate the type of the tumors. Actually, in less than 1% of cases, we have diagnostic challenge where we are not able to reach the diagnosis with the certainty. And I presented a case, the last case, which showed that we had a large tumor and we couldn't reach a final diagnosis. So we relied on inoculation as a diagnostic and therapeutic modality to reach our final diagnosis. Actually, biopsy per se for diagnostic issues, we didn't perform yet. And we had the case that I presented. We had another case of a 1.5-year-old girl that presented with unilateral a total retinal detachment with underlying tumor that was very large, and we treated the patient as unilateral group E retinoblastoma, where we performed inoculation, and the final diagnosis came out as malignant melanoma in a 1.5-year-old girl. We had another case of a young patient who presented with a large tumor and with retinal detachment, and the tumor was mainly based at the ciliary body. We couldn't see the features of the tumor because it was associated with dense detachment, as I said. So after discussion with the patients, we performed inoculation, and the final diagnosis was Rosset-Dorfman syndrome, which was the first reported case of Rosset-Dorfman that involved the orbit. And actually, we published this case. So biopsy for diagnostic, pure diagnostic purposes, we didn't do it usually. And most patients, they already have a large tumor that we are not 100% sure whether this is melanoma or retinoblastoma, but we are sure that this is a dangerous eye with no hope of vision, and we have to take the priority of saving the patient life. So we perform inoculation, and our great pathologists usually help us to set up our diagnosis and help our patients.
Okay.
Mona, you still do vitrectomy sample, as I remember. And
Now
you
we do vitrectomy for cases suspicious of lymphoma, intraocular lymphoma.
but you can do it also for metastatic diseases. And you remember the case with the metastatic signet ring cell carcinoma of the stomach.
But
it was diagnosed.
biopsy, yes, biopsy was mainly from the vitreous, but my answer is about tumor biopsies from the choroidal tumors or retinal tumors per se.
Okay, a final question from Dr. Sarah, also to Dr. Mona. Do you perform biopsies of the uveal melanomas for genetic analysis?
Actually, we don't do it yet, but we requested the kits, and we are about to set a plan to perform a cytogenetic analysis for all inoculated samples at KHCC. So far, unfortunately, we don't perform it, but we are in the process of establishing this test.
And for the BAP1 immune stain, I'm still waiting for it. So it is being ordered, and I'm keep asking about it. So I'm waiting for it to come in a few weeks.
Okay, thank you, Dr. Jacob. You already answered the question from Dr.
It's related to the genetic test.
Yes, she was asking about the BAP1 immunohistochemic testing. We have another question from Dr. Basma Saba. Did the girl have xeroderm?
No.
No, she didn't. Okay. We have a question from Dr. Nada Yaqut. Do you perform immunohistochemistry routinely for all uveal melanoma cases, and the preferred platform and the chromogen used in immunohistochemistry?
So I'm not doing routinely the immunohistochemistry for uveal melanoma. It's a diagnosis by histology, cytomorphology, and clinical diagnosis. In a couple of cases where I look for extraorbital, extraocular extension, metastasis, or in unusual case like this pediatric patient, I do some immunostains like HMB45, Milan A, SOX10, S100. So we use the automated machines. We have a couple or 3 automated machines, Ventana, and it is nice and easily detected with good with good controls.
Okay, thank you.
But it's not routinely used. So it's only, I use it for a couple of cases or 3 times only.
Can I just make a comment there?
Yes, please.
So we use, I agree completely that the diagnosis is predominantly clinical and also morphological on the basis of the histology, but we do the Melanoma stain routinely, just because we also do the BAP1 stain routinely. And by using the Melanoma stain, we can see if there are any fixation artifacts across the tumor, which, so if we have a nice homogeneous stain of Melanoma across the whole tumor, then we know that we should really have a similar homogeneous stain of BAP1 across the tumor. If we have patchy staining of Melanoma, then we can then also look at the BAP1 stain and see if that's also patchy. And we just, with respect to the chromogen, we usually use red for the Melanoma, but we find that the brown chromogen is better for the BAP1 stain, even though these are can be heavily pigmented tumors, but usually you can see the nucleus.
Yeah.
With
BAP1.
Yeah, which is important for the BAP1. And then there was another last question, which I can just answer very quickly. In the heavily pigmented tumors, to bleach them, we use hydrogen peroxide. I don't know the exact percentage, but the hydrogen peroxide does obviously remove a lot of that pigment, and that can allow you then to better judge the morphology of the cells.
Yeah. Okay. Thank you very much, Dr. Mona, Dr. Jacob, and Dr. Sarah for that great discussion. And this concludes our session. And now we'll go to the coffee break. Thank you so much.
Welcome. Thank you, everybody.
So our first speaker in the session is Prof. Bertel D'Amato. He'll be speaking to us about the clinical aspects of intraocular lymphoproliferative disorders. Prof. D'Amato received his undergraduate education in Malta, where he was born, and his postgraduate training in ophthalmology and ocular oncology in Glasgow. In 1993, he established the Liverpool Ocular Oncology Center, which he directed for 20 years. From 2013 to 2018, he was a professor of ophthalmology and radiation oncology and Director of the Ocular Oncology Service at the University of California in San Francisco. Currently, he is a Senior Clinical Research Fellow at the Nuffield Laboratory of Ophthalmology, Department of Clinical Neurosciences at the University of Oxford, as well as Consultant Ocular Oncologist at Moorfields Eye Hospital in London and St. Eric's Eye Hospital in Stockholm. Professor D'Amato has served as the President of the European Ocular Oncology Group, the European Vision and Research Association, and the International Society of Ocular Oncology. He published more than 300 scientific articles and authored and co-edited several textbooks. Professor D'Amato has received a number of awards, which include the Verem Medal in Denmark, the Cohen Medal in South Africa, the Watson and Ashton Medals in the UK, and the Platinum Award of the National Health Services of the UK. Prof. D'Amato, thank you very much for joining us. And if you would kindly start your session, please.
Hello, thank you for inviting me. I'm delighted to be speaking to you today. I'll try and get my screen to work. Fine. Can you see my screen?
It's all good, all good.
Good. So I'm going to be speaking to you about clinical aspects of intraocular lymphoproliferative disorders. My impression is that although we call this primary vitreoretinal lymphoma, I suspect that the source is somewhere systemic, perhaps in the bone marrow, I don't know. And this is because we had a patient a few years ago who had occlusion of the left inferotemporal retinal arterioles and then developed lymphomatous infiltrates throughout the fundus, except in the area of arteriolar occlusion. So what I think happens is that first you have the retinal infiltration, and then the lymphoma cells pass through the pigment epithelium into the subpigment epithelial space where they get trapped by Bruch's membrane. And some have asked me, how can the lymphoma cells pass through the retinal pigment epithelium? But the same thing happens with retinoblastoma. The cells can pass through the pigment epithelium and then they get caught by Bruch's membrane. Anyway, from the retina, the lymphoma cells infiltrate into the vitreous, and you can get optic nerve involvement, and also you can get spread to the anterior chamber, and so on. So that's what I think happens. Here's a patient with vascular sheathing in the acute stage, and then at a later stage, after treatment, there's areas of non-perfusion. Here is a patient with vitreous infiltrates, and sometimes these form pearls. And here's a patient with intraretinal infiltrates, as you can see from the OCT. And this has also spread into this space between the neurosensory retina and the pigment epithelium. And there's also a few collections underneath the pigment epithelium. Here's another patient with very subtle subpigment epithelial infiltrates throughout the fundus. They can be difficult to see, but it's easier to note them if you perform autofluorescence imaging. And here are some large subpigment epithelial deposits. Now, it's important to understand that most of the lymphoma cells in those deposits may be totally necrotic, except where they are close to choriocapillaris in the deepest part, where there can be an exchange of nutrients, oxygen, and so on. And it's important to know this because if you do a biopsy, it's important to go as deep as possible to try and get past the necrotic tissue into the viable lymphoma cells. Now, we all imagine that all patients with vitreoretinal lymphoma present like uveitis, but that's not always the case. Here's a patient who only had pigment epithelial changes, which progressed very slowly over several years, and the vitreous remained totally clear. And here's somebody with burnt out vitreoretinal lymphoma after treatment, and you can see the retinal pigment epithelial scars or areas of pigment epithelial atrophy, and these are hypoautofluorescent on autofluorescence imaging. Here's a patient with optic neuropathy from lymphoma. Here's a couple of patients where the lymphoma has infiltrated the anterior chamber, and in one patient forming a pseudo-hypopyon. So with regards to imaging, autofluorescence imaging is extremely useful. The active lesions are hyper-autofluorescent, whereas the areas of pigment epithelial atrophy are hypo-autofluorescent. And the autofluorescence imaging also shows the vitreous infiltrates as dark areas. And the autofluorescence imaging can also show patterns in the pigment epithelial scars. Here's OCT. I've shown you the intraretinal infiltrates, the subretinal infiltrates, the tumor deposits between the pigment epithelium and Bruch's membrane. Some patients develop scars under the fovea, and although it's not widely known, a few patients can develop cystoid macular edema and even epiretinal membranes. Some patients with lymphoma only have vitreous infiltrates without any pigment epithelial changes. And other patients have only pigment epithelial and retinal abnormalities without any vitreous infiltrates. So there's a sort of spectrum. With regards to differential diagnosis, you need to think about different infections, non-infectious uveitis, different tumors, melanoma, metastasis, sclerochoroidal calcification. And then there's a number of investigations, first the history, full ocular examination, imaging, as well as systemic investigations looking for infections, CNS involvement, and so on. Because most of these patients eventually will develop CNS disease. And really important is vitreous biopsy, and Professor Copeland will be speaking about that later. With regards to treatment, there's ocular treatment and systemic treatment. Ocular treatment, there's external beam radiotherapy. It's very effective, but you can get a recurrence either from minimal residual disease in the eye, or perhaps because of spread of tumor to the eye from a distant source after completion of the radiotherapy. And intravitreal methotrexate, that's what most people seem to be giving. First twice a week, and then once a week for a month, and eventually once a month. It's a lot of injections you have to give. This patient had a dramatic response after only one injection, but most patients need repeated injections. And you can get keratopathy, hypotony, macular edema, uveitis. You can get quite a lot of side effects from this treatment. Although it can be really useful. Here's a patient who had recurrent disease after radiotherapy, who did well after intravitreal methotrexate. Then there's intravitreal melphalan, proposed by the Shields a few years ago. And we had a patient who tried it and gave an injection once a month. And it seemed to be quite effective, but it had to be repeated every month because the disease kept recurring. Intravitreal rituximab is also given once a month. And as far as I know, I haven't tried it myself, but it seems to give very good results as well. There are some who believe, well, quite a few people believe that that in ocular treatment, and this study suggested that systemic therapy is ineffective and dangerous. And my impression is that systemic chemotherapy is dangerous if it is not, especially if it is not administered by an experienced team of hemato-oncologists who are giving that kind of treatment all the time. As to whether or not systemic chemotherapy is effective or not, I'll come to that. Because when I was in San Francisco, I was fortunate enough to be working with James Rubenstein, who specialized in CNS lymphoma, and therefore I received patients from far and wide. And so if I had a patient with vitreoretinal lymphoma, I didn't do anything. I passed the patient on to him, and he treated my patients for me systemically. And first there was high-dose chemotherapy, induction therapy with high-dose systemic chemotherapy and rituximab, then consolidation. But really important was maintenance therapy with lenalidomide, an immunomodulator, and rituximab. And then if there was recurrence, then there was high-dose chemotherapy again. With regards to radiotherapy, quite a few people administer whole brain radiotherapy, but this can cause dementia. And so, if possible, only focal radiotherapy to intracranial tumors was administered. Here's a patient with vitreoretinal lymphoma who had only systemic therapy with a very good result afterwards. And this shows the difference between chemotherapy alone and chemotherapy followed by maintenance immunotherapy to keep the minimal residual disease suppressed. And you can see that the big improvement with the maintenance immunotherapy. You'll be hearing more about the pathology of lymphoma, and there's the germinal center B-cell-like lymphoma, GCB, and the activated B-cell-like lymphoma. And this is becoming more important with regards to treatment because there are different immunomodulators, and some work against one kind of lymphoma and others work against a different kind of lymphoma. So that here's a patient who would not have responded to the usual lenalidomide, but did respond to CC122 because we knew the type of lymphoma that the patient had. Systemic chemotherapy is, I could see that it was quite effective for vitreoretinal lymphoma, except when there were dense vitreous infiltrates. Just like retinoblastoma, systemic chemotherapy is effective, except when you have vitreous seeds, when it is less effective. But we also found that vitrectomy enhances the efficacy of systemic chemotherapy. Here's a patient who had a vitreous biopsy from the left eye with removal of all the vitreous because he also had a detachment and had further vitrectomy as part of treatment for the detachment. This was before he came to us. And so the left eye never showed any more signs of lymphoma, but on the right side, there were dense vitreous infiltrates that were resistant to the systemic chemotherapy. And so we did a vitrectomy, a therapeutic vitrectomy in the right eye, which was very effective. And so the systemic therapy became more effective. And here's another patient who also did very well with therapeutic vitrectomy, which improved her vision. So we did a study on the patients that who were treated mostly by me and Dr. Rubenstein. And the large majority of patients, after a few years, had the same vision as they presented with. One or two patients developed visual loss, one after complications following cataract surgery, and another from that subfoveal scar. And the other patients showed an improvement in vision, but most had the same vision that they came with. And they were all alive and at the time I moved back to the United Kingdom from San Francisco. But we really need more studies to show whether this approach actually does prolong life or not. Now I'm going to speak about the uveal lymphoma. This is totally different. It's a low-grade lymphoma, which you'll be hearing more about. So the retinal lymphoma, the vitreoretinal lymphoma is a high-grade, aggressive B-cell lymphoma with CNS disease and a high mortality, whereas primary uveal lymphoma is a low-grade MALT lymphoma, extrazonal marginal zone lymphoma, extranodal marginal zone lymphoma with a good prognosis. And here's a patient we saw, and you can see the fundi look very similar, except in the left eye, the choroidal vessels are less visible. There's the Optos pictures, autofluorescence, not much difference. But then on ultrasound, you can see the diffuse choroidal infiltrates, a bit similar to diffuse choroidal hemangioma, but with hemangioma, you have a very high tumor reflectivity, whereas with lymphoma, there's a low internal reflectivity. And this tumor also shows extraocular extension near the optic nerve, which is very common. And on OCT, in the right eye, it's normal. You can see how thin the choroid is. You can see the choroidal vessels, a flat surface. Whereas in the left eye, it looks lumpy and thickened, and you can't see the choroidal vasculature anymore. And then you get this extraocular spread, not only posteriorly, but also anteriorly. You can, into the subconjunctival space, you get the salmon pink tumors. You can get iris involvement. And we had, in Liverpool several years ago, we had a patient with a ciliary body lymphoma, which is very rare. Then there's secondary lymphoma, typically with these multiple creamy deposits. And recently, Carol and co-workers have described indolent uveal lymphoid infiltrates, which just seem to sit there and not doing anything. And we had a patient like this at Moorfields in London recently, with these multiple deposits visible on OCT. The patient was asymptomatic, and 8 months later, there was no change, there were no problems, so we just continued to observe that patient. So the common term that was used was primary intraocular lymphoma, PIOL, and Professor Sarah Copeland and I didn't like that term, and so we've been trying to discourage that term because it does not distinguish between the vitreoretinal lymphoma and the uveal lymphoma. And also, we say it's primary, but we're never quite sure whether it actually is primary or secondary. Even if a patient presents with vitreoretinal lymphoma and then later develops CNS lymphoma, it might be that the CNS lymphoma preceded the vitreoretinal lymphoma, except that it was subclinical, and it was just the retinal lymphoma that presented first. So we really need to think about the retinal lymphoma, which is mostly vitreal or retinal or subpigment epithelial or combined, and the uveal lymphoma. So in summary, there have been several advances in retinal lymphoma: wide field imaging, autofluorescence imaging, OCT, vitreous biopsy, which you'll hear more about, intravitreal methotrexate, melphalan, rituximab, radiotherapy, systemic therapy with chemo, and not only chemo, but also immunotherapy, and also therapeutic vitrectomy for resistant intravitreal infiltrates. But my impression is that ocular treatment is only palliative. Not everybody agrees with this. It's very, very controversial. And my impression is that systemic therapy may delay or prevent CNS disease, but not if it's just given in a short course, but also especially if it's followed by long-term maintenance to suppress any minimal residual CNS disease. So in conclusion, patients will benefit from recent advances, but only if they receive early diagnosis and not many months of treatment for uveitis, and if they receive multidisciplinary care with ocular oncologists, hemato-oncologists, pathologists, and so on. So that brings me to the end of my talk. I'd like to acknowledge my co-workers, past and present, and I'd like to thank you all for your attention. Thank you very much.
Thank you, Prof. Thank you very much for your very comprehensive talk, lovely pictures, and thank you for sharing with us your research. It's been a very catching talk. Thank you. Our next speaker is Professor Copeland. She'll be speaking to us about the pathology of intraocular lymphoproliferative disorders. Prof. Copeland is a senior consultant histopathologist at the Liverpool University Foundation Hospital Trusts in Liverpool, UK, with expertise in ophthalmic pathology, hematopathology, molecular and digital pathology, and biobanking. In 2006, Professor Copeland established the Liverpool Ocular Oncology Research Group, a multidisciplinary team focusing on ocular melanomas, lymphomas, and other eye cancers. She is the George Holt Chair of Pathology at the University of Liverpool. Prof. Copeland is a current Vice President and Genomics Lead of the Royal College of Pathologists. She is also General Secretary of the Pathological Society of Great Britain and Ireland. She has published around 330 scientific articles and written around 150 chapters, including some within the UICC TNM staging system for ophthalmic tumors, as well as the WHO tumor volumes. She has won several awards for research and teaching, including the International Council of Ophthalmology's Eye Pathology Award and the 2019 RCPath Excellence Award. She was included in the pathological power lists of 2019, 2020, and 2021, and was also listed in the top 100 influential women in ophthalmology in 2021. Prof. Copeland, please start your session.
Thank you very much, Fatima. That was, I'm feeling rather embarrassed by that introduction. Thank you very much, and also for your invitation, Maisa, to this workshop. So I will just share my screen. So can you see that?
Yes.
Okay, I'll just put it on. So now you should be able to see the full screen as well. Okay, I hope so. If you,
it's clear. Yeah,
that's great. That's wonderful. So thank you. I'll be speaking about the pathology of intraocular lymphomas, and there is a bit of overlap with the discussion and that Prof. D'Amato just showed. But hopefully you'll forgive that, and I think repetition is always good. So I'm just going to go back to the basics. In that, as you know, that lymphomas essentially can be divided into Hodgkin and non-Hodgkin lymphomas, and then the non-Hodgkin lymphomas can be further subdivided into the B, T, and NK subtypes. And then anatomically, they can be divided into those occurring within lymph nodes and those which occurred outside the lymph nodes, extranodal lymphomas, and they obviously include the eye and the ocular nexal structures. So when it comes to the diagnosis of lymphomas, then we all are using the WHO lymphomas classification system. This wasn't always the case. The WHO lymphoma classification system really has only been in effect since the turn of the century. And it takes into account the clinical aspects, the histomorphological aspects of the tumors, the immunophenotyping, and also the genotyping of the tumors. And this is all based around the proposed cell of origin of the lymphoma or leukemia. As you all know, molecular genetics has gone through a rapid revolution over the last decade. And so we're not only using gene expression profiling, but we're using genomics, and this includes next generation sequencing and the inclusion of transcriptomics and all sorts of methodologies which are revealing mountains of information, enabling us to better understand the biology of lymphomas and leukemias, but therefore also making our reports rather more complicated. So the WHO obviously has to incorporate as much of the new information as possible. And I'm just going to go through a wee bit about the WHO Blue Books, which you all know about as pathologists and oncologists. So they are, at the moment, the head of the IARC, or the IARC, which essentially organizes the WHO Blue Books, is Professor Ian Cree. And he has, I think, revolutionized things by placing everything electronically, such that there is greater flexibility with the WHO books, incorporating all of this new information as quickly as possible. And you'll probably recognize this, the 5th classification. So he was very much involved in producing the 4th, 4th and 5th editions of the WHO, and these are the ones of the 5th classifications, and they have a standard format, and not only printed but also available online with additional images and also whole slide images which people can zoom in remotely and look at. So I guess the advantage of the Blue Books is that there is, and this new electronic system, and something that which really accelerated as a result of the COVID pandemic, was that there is the editorial boards for each of the Blue Books is a lot larger. And it is, he has tried to incorporate representatives from all corners of the earth, so to say, so that there is no biased viewpoint in terms of the pathology of certain diseases. And he's applied sort of Linnaean principles to the hierarchy of the classification of the tumors, and I'll come to explain that in a better way shortly. But this has improved digitalization has led to the improved process management and also rapid production of the editions. So I've been involved in the lymphoma book. I've actually been involved in the lymphoma book, the eye book, and the skin book. And the Hempath book has taken a considerable effort over the last year. It has 25 expert editors, 380 authors, and 31 countries are represented in the authoring of the book. And this is just a map of all of those who've been involved in the editorial board and those who've been writing. So there is indeed an effort to get a global view of the epidemiology and the perhaps differing geographical differences between the varying entities in lymphoma. This is an example of a Zoom meeting where we would, the editorial board, where we'd go through every single chapter, every single figure, and make sure that all of it was correct. And some of these meetings were really marathon meetings, lasting from close to 12 hours. It took, as I said, a large number of authors writing the books, and this is the timeline. So we are now at the stage where the Hempath, the 5th edition of the Hempath book, is near to complete. It is with the WHO editorial team, and it's projected that it will be released towards the end of this year. 2 papers have been submitted to leukemia review papers as introductions to the 5th edition and highlighting the major changes between the 4th and the 5th edition. So watch this space, it won't be far away. Just also mention that I was also involved in the iBook, and this is a photo of us when we met in Lyon, and this is Prof. Cree in the middle. This was at a time when the editorial boards were really quite small, and we met physically. But both Prof. D'Amato and I are involved in the 5th edition of the WHO book, which is in the process. It's really only about a third of the way through. And it will not only include the eye updates on the ocular tumors, but will also include the eyelid tumors and also the orbital tumors. So this is a significant contribution and change. And so this book will be probably double the thickness. Okay, so returning to ocular lymphomas, essentially they can be divided into ocular nexal lymphomas and the intraocular lymphomas, and we do use obviously the WHO lymphoma classification to subtype them. I can obviously only concentrate on the intraocular lymphomas today, but I just want to highlight that the most common lymphoma subtype occurring in the ocular nexa is the so-called Mort lymphoma, with the second most common being the diffuse large cell B-cell lymphoma. Whereas in the eye, it's almost the reverse, with the most common being the diffuse large cell B-cell lymphoma, predominantly occurring in the vitreoretina, with the low-grade B-cell lymphoma, as Prof. D'Amato said, occurring in the uveal tract, but predominantly in the choroid. So in the 5th edition of the WHO, the vitreoretinal lymphoma has been included within a group of what are called immune-privileged site lymphomas, and these include vitreoretinal lymphoma, CNS lymphoma, and testicular lymphoma, and it could well be with time that other lymphomas are put under this umbrella. So as we've heard, vitreoretinal lymphomas they're relatively rare, but their incidence is increasing, and this is not only in the immunocompromised patients, but also in those that are immunocompetent. And they typically occur, excuse me, between the 5th to the 7th decade of life. And as was shown by Prof. D'Amato, there is a spectrum, those that occur only within the retina, those which involve both the vitreous and the retina, and those that only occur within the vitreous. It can lead to the so-called masquerade syndrome, mimicking a chronic uveitis for years. And this does then lead, unfortunately, to a delay in the diagnosis. You can have concomitant or subsequent involvement of the brain, and it is usually the involvement of the brain which leads to the demise of the patient. So you've seen some images already from Prof. D'Amato. These are care of Prof. D'Amato. This is a vitreoretinal lymphoma involving both the vitreous and the retina. You can see the haze in the retina, the haze in the vitreous with this leopard skin-like pattern of hypo and hypopigmentation in the retina. And here's the OCT where you can see these nodules within the retina and probably also in the subretinal space. And here again, this typical morphology which points towards the diagnosis of vitreoretinal lymphoma. So when it comes to the diagnostics, what happens is that we typically receive either a vitrectomy, which is probably in most cases, and we receive an undiluted sample, and then more often not an additional diluted sample in a larger cassette. And what we do here is that we receive these samples, and I'll come to fixation later in the presentation, but we receive these samples and we create cytospins. Something that I don't really like is the embedding of these samples into paraffin wax, and I'll go into that later. Why I don't really like that. But so you receive the sample, we create a cytospin, we stain with MGG, we automatically create 3 unstained cytospins, one for a B-cell marker, because the vast majority of these, 99%, are B-cell lymphomas. We have a cytospin for a B-cell marker, CD20, one for a T-cell marker, and one for macrophages, because more often not, because of the significant necrosis which is associated with these tumors, we like to work out any atypical looking cells and determine whether they're macrophages or whether they're indeed B blasts. And more often not, because they're high grade, they have a high Ki67 proliferation rate. Occasionally we get subretinal aspirates, and occasionally, something I'll go on to, we get chorioretinal biopsies. So the subretinal aspirates, depending on how cellular they are, and the chorioretinal biopsies, they can go in formalin, and they obviously can be embedded. Some people prefer to do the immunophenotyping, not using the immunocytochemistry or immunohistology. They prefer to use using flow cytometry. This is all a matter of experience, and it's just the vitreous is quite tricky because it is very gel-like, and so there has to be a bit of pre-treatment of the vitreous prior to the use of it in the flow cytometer. Other labs use the ratio of interleukin 10 versus interleukin 6. We don't do that here. What we tend to do is do the cytospins, the 3 cytospins that I mentioned in terms of the immunocytology. We reserve some of the sample for DNA extraction. We extract the DNA, and according to its concentration, we either do PCR, polymerase chain reaction, for the rearrangement of the heavy immunoglobulin chains, or we do MYD88 analysis. MYD88 gene mutation has been demonstrated in 71% of vitreoretinal lymphomas, and therefore is quite valuable in cases where there's a low concentration of DNA. And it has been demonstrated that you can, in some cases, pick up the MYD88 mutation in an aqueous humor tap. Other methodologies include metagenomics, and also something that is developing in all areas, all cancer areas, are next generation sequencing panels, which are bespoke for particular tumors. And Canny and co-workers first designed the first next generation sequencing panel for vitreoretinal lymphoma, and that was using MYD88, CDKN2A, and ACT-T1. In the meantime, other groups, including that led by Falco Fend in Tübingen in Germany, they've developed a multi-gene panel and also looking at copy number variations. And I was involved in this, and this came out late last year, where they look at MYD88, CD79B, and also some other genes, but also this copy number variation in chromosome 9. More on the research arena, there is the use of microRNAs. This is evaluating the supernatant, not the cellular component of the vitrectomies, but the supernatant after the spinning of the sample, looking at this particular constellation of microRNAs, which has been demonstrated to be of value in differentiating a lymphoma from a chronic uveitis. However, this isn't really used in the clinic at the moment for diagnostics. So just to say, yes, we do occasionally get subretinal aspirations and chorioretinal biopsies. The advantage of the chorioretinal biopsies is that you can do quite a few immunostains. And as Prof. D'Amato alluded to, most of the vitreoretinal lymphomas are diffuse large cell B-cell lymphomas of ABC subtype. That is, they aberrantly co-express MUM1 and BCL6. Normally, B cells express either MUM1 or BCL6, not both, but this co-expression is a further indication that these are neoplastic B cells, and also this combination plus the negativity of CD10 pushes it towards being a lymphoma which has arisen from a cell which is exiting the germinal center, and is a diffuse large cell B cell lymphoma of ABC subtype. Again, showing the high Ki67 proliferation. There have been further genomic investigations of both primary and secondary vitreoretinal lymphoma, and this is the work again by Falco Fend in Tübingen in Germany, and using whole genome sequencing, they've identified, further validated the MYD88 mutation, but also the importance of the CD79B, this gene PIM1, and ETV6. And they've compared, and also the prevalence of the deletion of chromosome 9 in most of the cases. They did a comparison of primary vitreoretinal lymphomas, those which were synchronous with CNS lymphomas, those which were secondary to CNS lymphomas, those, and also in a combination, these were exceptionally rare cases where there were also, the patient initially had testicular disease and then developed CNS disease and also simultaneous ocular disease. But what they were able to identify that there were differing gene mutation patterns, and whilst MYD88 didn't differentiate between a primary and a secondary vitreoretinal lymphoma, the other mutations did help differentiate between primary and secondary vitreoretinal lymphomas. And I just want to highlight what's going on in other fields is that there have been these exhaustive examinations of diffuse large cell B cell lymphomas occurring in differing sites, and they've been able to not only subdivide the diffuse large cell B cell lymphomas into ABC and GCB subtypes, but also into clusters, and there are 5 clusters for DLBLs. And the vitreoretinal lymphomas, with this combination of the MYD88 and the CD79 beta mutation, places them within the C5 subgroup. And this is important because it has been demonstrated that the C5 MCD subgroup, as it's called, is associated with a poor prognosis, which fits most of the clinical outcomes in vitreoretinal lymphoma. So this is a table which is going to be included or has been included in the leukemia paper, which I mentioned, and will be included in the upcoming 5th edition of the HemePath Blue Book. And this is just how primary vitreoretinal lymphoma fits into these so-called clusters, and also how how the similarities of vitreoretinal lymphoma with CNS lymphoma, and indeed those of the testis, all justify them being in this umbrella term of the immune privileged site lymphomas, and also because of their very similar mutational patterns, including also the expression of various proteins which enable them to evade the immune system. So this is just a summary of the vitreoretinal lymphomas. The clinical features, the vast majority being diffuse large cell B cell lymphomas. They have something that I didn't mention is they have a very high somatic mutation load similar to CNS lymphomas, and the vast majority are ABC subtype. There are occasional cases which have been described as GCB subtypes, And when it comes to this new clustering system, they belong to the C5 MCD group. I'm just going to move very briefly onto the primary choroidal lymphomas, which were mentioned. These are relatively rare, although I think now that they've been recognized, I think their rarity, they may not be as rare as we think, because it is no longer all that novel to write up a case report about a primary choroidal lymphoma. What may be more of interest is to write up a series of choroidal lymphomas and the associated genetics. But for many years, they were given different terms, including pseudotumor, hyperplasia, and neoplasia. And it was only when I worked collaboratively together with the AFIP, when it existed, that we examined the morphology and the immune profile, and we gathered sufficient evidence to be able to call it the marginal zone B-cell lymphoma of mold type in the choroid. You've seen some of these images already from Prof. D'Amato. What is different about these lymphomas in the eye is that they occur in the choroid. They do not affect the retina. As you can see, that the pristine retinal blood vessels are not affected by this, and they do not involve the CNS. So there's no fear that these tumors will spread to the CNS. So this is an enucleation sample. Now, you actually don't often get such samples, but this was a case where there was extensive involvement by the neoplastic cells of the uvea, involving the ciliary body as well, and passing extraocularly via the exiting nerves through the sclera. And this, you can see, is sort of high power. And what is typical about these is you have reactive germinal centers, and the neoplastic cells are within the marginal zone. They can show a significant plasmacellular differentiation, as you can see with mold lymphomas elsewhere, such as in the conjunctiva. They are small cell B-cell lymphomas. You can see that because here are erythrocytes, and they're about the same size as the red blood cells. And they have a low growth fraction, as demonstrated here with the Ki67 stain. So they are really a low-grade B-cell lymphoma. The patients shouldn't be treated aggressively. More often not, they can be treated with low-dose radiotherapy. And something that I didn't mention is that they, yes, arise from the marginal zone, and therefore they are post-germinal center B cells. Prof. D'Amato mentioned that very occasionally you can get lymphomas occurring in the iris, and these more often not can be very aggressive. This is odd that those that occur in the iris are more aggressive than those that occur in the choroid. They tend to be diffuse large cell B-cell lymphomas, although some T-cell lymphomas, primary T-cell lymphomas of the iris have been described. And then something that we can't forget is the secondary uveal lymphomas. So these are lymphomas which, where the patient is known to have a systemic non-Hodgkin lymphoma. And then there is, late in the course of the disease, there is a systemic manifestation of the lymphoma in the uveal tract, typically in the choroid. The exact incidence isn't clear, but this is an example here of a patient with a CLL involving the choroid. And there was positivity for CD20, CD3, and CD5, as you would expect in CLL. This was an unusual case of an intravascular lymphoma, which involved the blood vessels within the iris and also the choroid. These are exceptionally rare tumors, but very aggressive. And sorry, this isn't just an example of secondary lymphoma, and a clinical example. And I think Prof. D'Amato showed these pictures. So even though this article is very old, inverted commas, it's from 2008, I think it still holds true in helping people understand the how you can view intraocular lymphomas from the anatomical viewpoints, because this anatomical breakdown of the lymphomas within the eye helps you understand also their aggressiveness or not. Just to say, there are always differential diagnoses that you have to consider. And yes, the chronic uveitis, obviously, but also the infectious uveitis and also vitritis. And this, particularly in immunosuppressed patients, you have to think of toxoplasmosis. And I've had a couple of cases where I was sent a vitrectomy and there were the typical toxoplasmosis cysts. This was a case where the eye was enucleated and there were masses of toxoplasmosis cysts within the choroid and the retina. And this, you can see actually, it corresponded to this case, and there was this extensive scarring. It was very difficult for the clinicians to come up with a definitive diagnosis. And unfortunately, ultimately, the eye had to be removed to obtain this. Also think of, in patients with immunosuppression of fungal diseases such as Candida, and in some cases of aspergillus, which can be very aggressive. So when it comes to sending samples to the clinic, and this is a plea to the clinicians, please, first of all, do not send it in glutaraldehyde. This is very much a fixative, I think, of the past. And for electron microscopy, we don't require that in most cases in ocular pathology. If it is a tissue chunk, a tissue biopsy, then that should just go in buffered formalin as per usual. And then a whole range of different molecular techniques can be undertaken using that tissue. If you are sending in fluid samples like a vitreous or a loose subretinal aspirate, then consider putting it in a soft fixative such as Cytolite or the Hope fixation. And with that, then you can create your cytospins and for both the conventional staining and also the immunocytology. And then you can also extract the DNA from them and perform your IgH-PCR or the MYD88 analysis. But obviously, if you're thinking of some infectious cause, then you should send some of the sample to the microbiology department. But most importantly, speak to your pathologists. Let us know when the sample is coming or when the operation is being planned. And please do not send these vitrectomy samples on a Friday afternoon or late, because unfortunately they will only be found on the Monday morning. And since these cells are so fragile, they will more often not undergo further necrosis, and the yield in terms of the diagnostic yield would be significantly reduced. So just to summarize there, when it comes to the diagnosis of intraocular lymphomas, I'm still very much a conventional pathologist and thinking that morphology plays a significant role, followed by the immunophenotyping. Then we also have the battery of molecular tests, and these are pretty much guided by the concentration of the DNA. And I think if we get more material, then we'll be able to understand the biology, and through that, then we'll be able to come up with novel targets. And it's only because this is such a rare disease, that through the concerted efforts that we'll be able to improve the outcomes of vitreoretinal lymphomas, and obviously improve the patient's prognosis. So this is a picture of Liverpool, which Jacob will probably recognize. And I just want to conclude by saying again, yes, thank you very much for organizing this to be as part of the Diamond Jubilee celebrations. An event that is happening during the year is the college is teaming up together with Cancer Research UK to do a Land's End John O'Groats cycle ride. This is from one corner of the UK to the other tip. This is approximately 874 miles. There's a team of about 25 cyclists who are doing this, including myself. So hopefully my wheels will be able to get me this length of journey, and I will be fundraising for Cancer Research UK. And if you're thinking of perhaps sponsoring me, this is my fundraiser page. So with that, I'm happy to take any questions, but they may well be at the end of the case presentations. Thank you. So
thank you very much, Prof. Copeland, for such a wonderful talk. We feel very privileged and lucky to have first seat listening to you and Prof. D'Amato. I think we'll go ahead with the case presentation, and then we'll have 10 minutes for questions.
Okay, so I have a case. I don't know whether Prof. D'Amato has a case or not, but I can show you what I was showing you in my presentation were, I guess, typical cases, you know, a typical workup of what we do. So I'm going to show you perhaps a tricky case that's stumped quite a few people along the way. So I will just find that presentation and come back to you one moment. So I'll just share my screen. Can you see that?
Yes.
Yeah, it's all there. Yeah.
Okay. Okay, so this is, I'm giving away the diagnosis in the title, but so this is a case which involved the clinicians in Belfast, in Liverpool, and Yamini Krishna, who's an ocular. She's actually an ophthalmologist who then did a retraining in pathology, and so she completed and passed her second part exams last year, and will hopefully become a consultant histopathologist in the very near future, specializing in ophthalmic pathology. So I'm going to present this case here. 75-year-old Caucasian male who had a 1-year history of streaks in his vision, who went to his optometrist in December 2020, and he had a decrease in vision in his left eye. There was no cause found, and I'll show you the picture shortly, but this continued, or this was progressive, and he represented in A&E in March 2021 with a significant loss of vision down to hand movements only. What is important that, yes, obviously during this time there wasn't any foreign travel, but he didn't have any trauma and he didn't have any pain. There was no history of fracture. The only history that he had was hypertension, Barrett's esophagus, celiac disease. He had high blood pressure, and he was a smoker, but had stopped a good decade ago. So these are the images from the optometrist. So yes, right side vision in the right eye was aided, but 20/20 or 6/6 in the left eye was reduced, and he had sort of a vague haze within the vitreous, otherwise pretty much normal. So this is a summary of the examinations. And I'll move shortly to to show this old peripheral scar, which was seen in more detail when an optos examination was undertaken. So this is the optus of the right eye, the unaffected eye, and you can see this peripheral scarring here. And it's important you perhaps try and keep this image in mind because of the later progression of the disease, which I won't come to. Which I will come to. So in April 2021, yes, things got significantly worse, and he underwent a vitrectomy, And this is the pre-operative imaging. So you can see that it, the view into the fundus was significantly hindered, and such that OCT and ultrasound, etc., had to be undertaken to try and work things out. And you can see there was this thickening in the retina, but also involving some part of the choroid. Further investigations were undertaken. All sorts of investigations undertaken. The only thing that came up positive, interestingly, was a positivity for toxoplasmosis. This was his CT scan of the chest, which wasn't really significant. There were no lesions within the X-ray, within the CT, which would suggest that there may have been a carcinoma as a result of his smoking. And there similarly was nothing to see in either the brain or in the orbit. So then, yes, in Belfast, a vitrectomy was undertaken. It wasn't a full vitrectomy. It was just I guess a small vitrectomy where there was only a tiny undiluted sample sent to the pathology team there. No malignant cells were seen. The microbiology, etc., were all negative. But interestingly, the PCR was undertaken on the vitreous, which must admit something that's not done routinely here, but was done there, and there was EBV positivity. As things progressed and there was no clarity with the diagnosis, a full vitrectomy was undertaken together with removal of the lens, and this was sent again to the pathologists in Belfast. This is post-operative imaging, so showing that unfortunately their eye is a bit of a mess, and that's showing. You can tell that I'm not an ophthalmologist in terms of the explanation of what is being seen. But this was the sample that was finally, after probably several months, sent to us. This was the vitrectomy was worked up. It was placed in formalin, and then was placed in an agar block, and then serial sections were undertaken, but no immunohistochemistry was undertaken. So even though there were quite a few cells here, it could not be determined because of the lack of immunohistochemistry of what type of cells these were. So a bit unfortunate that the processing of the sample wasn't optimal, and therefore perhaps a key to the diagnosis couldn't have been obtained earlier. So in June 20, this is, I guess, where we came in. The patient was referred to the Ocular Oncology clinic in Liverpool, and with the strong suspicion of it being lymphoma, but with this confusing aspect of being EBV positive, and with the suggestion that perhaps there could well be metastases as well, although nothing was seen on the CT scan. So multidisciplinary team meetings were undertaken, and it was decided that a nucleation should take place. Simultaneously, they saw that there was an enhancing lesion in the region of the ethmoid sinuses, and there was a question whether this could be an inflammatory, whether the two could be linked. So the eye was received by ourselves. As you can imagine, as from those images of the post-operative images, it was really quite a, there were numerous pathological changes within the eye. When we looked in detail and did several levels, we saw a couple of foci of increased cellularity within the retina, and also spreading into the superficial choroid. And these foci were only sort of dotted occasionally within the levels. So this is this focus here. And when we did the immunohistochemistry, we did the typical B stains, we did the CD79A, the CD20, and also the PAX5. Hardly any cells came up, but what did come up were sort of dense infiltrates of T cells coming up with CD3, and then interestingly also with CD8, some quite strong cells, others fainter, but there were also necrotic areas. They also stained for CD56 and for granzyme B, and there was a high proliferation rate. So we had our suspicion that this was a TNK lymphoma occurring in the eye. I was simultaneously speaking with the pathologist in Belfast who was working up the ethmoidal biopsy, and they came up with the same diagnosis. And in their larger specimen, they were able to demonstrate the positivity of EBV. In this specimen that we had, we could demonstrate T cell clonality. The story does continue. The patient unfortunately started developing a decrease of vision in his right eye, and you can see the OCT images, these nodules in the subretinal space and spreading along and sometimes involving the choroid. So it was then decided that the patient should receive urgently intravitreal methotrexate, and underwent staging to see if there was any, the extent of the disease. And it was decided, because of the involvement of their ethmoid sinuses and some supradiaphragmatic lymph nodes, that the patient should receive chemoradiotherapy, and this is the combination that he received. Quite fortunately, when we contacted the clinicians in Belfast in January this year, the patient was in remission and didn't have any lesions within his right eye. And so obviously had, as a result of the nucleation, lost vision in his left eye, but the disease seemed to be under control within the right eye, and there were no CNS lesions. So just to summarize, nasal NK T-cell lymphomas can involve and spread to the eye. When I say the eye, they can involve the ocular nexal structures, and we've reported that before, involving the eyelid and the orbit, but there are less than probably 10 cases where it's been described to involve the eye and actually be the presenting symptom of nasal NK T-cell lymphoma. They're typically highly aggressive and usually have a poor prognosis. So we were actually quite surprised, but very pleased that the patient was in remission when we contacted the clinic in Belfast at the beginning of the year. And with that, I'd like to thank you all very much. These are a list of the references of TNK lymphomas which involved the eye and ocular nexa. And I had particularly, I was hoping, oh, there we are. I wanted to show you an image of Yamini Krishna, who helped me work up this case and provided many of the images. So thank you very much.
Thank you, Prof. Copeland. That was such an amazing case. We learned so much about the approach. We have a question from Dr. Maysa Al-Husseini. She's wondering if COVID-19 affected the presentations and the outcomes of ocular malignancies in terms of the delay of diagnosis.
Definitely. So not only in the lymphomas, but also in all tumors in and around the eye. So I don't know what happened in your countries, but here in England, more often, well, what happened was the GPs had to do most of their consultations online, and then only in urgent cases were the patients then referred to the ocular oncology centres. So in England, there are 3 adult ocular oncology centres, one in London, Liverpool and Sheffield. For the children's tumours, the retinoblastomas, they're in Birmingham and in London. So we still kept on seeing eye cancers here because fortunately St Paul's Eye Clinic has a separate operating theatre. Some of the larger operating theatres had to be converted into intensive care units. And so there was a significant reduction in surgeries of all types. But fortunately, because St Paul's Eye Clinic has its separate operating theatres, then the eye cancer patients could still be seen all throughout the COVID pandemic, albeit they were seen in reduced numbers. But now and it's something that we'd actually like to assess, we have the impression that most of the patients presenting post-pandemic, although we're not really 100% out of this pandemic, is that a lot of the tumours are larger. A lot of the eyelid tumours, the orbital tumours, the intraocular tumours are larger, and I'm sure that's going to impact on the outcome of the clinical course of the patients.
Do you think that's related to the nature of the virus, how it kind of like affects the immunity, the immune response within the body, or does it have to do more with the delay? Because, you know, like in certain organs, it feels that the virus did have an effect on kind of like the biological behavior of some tumors.
I'm not sure about that. I don't know whether anybody's examined that. I know that people have looked at COVID receptors on the conjunctiva and potentially in the eye. But I don't know whether anybody, apart from delayed presentation, whether anybody has done a study about COVID and any ocular tumors.
Prof. D'Amato has mentioned something about you having a different take on systemic versus the systemic versus primary nature of lymphomas in the eye. Could you elaborate more about this?
Well, I think this is it's still up for debate. I know that I think one group has demonstrated that there, in some patients with CNS lymphomas and possibly vitreoretinal lymphomas, that there are neoplastic B cells in their bone marrows. Okay, so, but I don't know whether this has been reproduced. And so there is this one hypothesis that there are circulating neoplastic B cells which have then zoned to the immune privileged sites, i.e. the eye, the CNS, or the testes, or other immune privileged sites. I think we're still far from understanding why, when you have a vitreoretinal lymphoma, why it stays pretty much within the CNS system. So it stays within, it either goes to the CNS or it even may spread along, obviously, the spinal cord. And similarly, if you get a relapse of testicular lymphoma, these relapses can occur within the brain versus anywhere else. They don't spread out outside the testes, they spread to the brain. And so nobody really understands this, but it could well have something to do with the chemokine receptors of the tumor cells, and the ligands, the corresponding ligands. So we're still working it out.
It's very interesting.
We don't have the appropriate models, really, unfortunately. So there has been done some work done in mouse models, but I don't think the mouse model really truly replicates the human situation.
Sarah, I probably have a question.
Okay.
Intralacrimal or actually lacrimal lymphomas, do they have like the same kind of presentation, treatment, prognosis to the one actually affecting the eye itself?
So the lacrimal gland belongs to the ocular nexa, and the most common lacrimal gland lymphoma would be a MALT lymphoma, so low-grade B-cell lymphoma, and so they you know, the patients present with differing symptoms. So obviously sort of like an orbital mass, which may then press on the eye and cause visual symptoms, or but they're more often not treated with low dose radiotherapy. And actually the dose of the radiotherapy it used to be about 30 or 40 gray, but it's being reduced significantly down to about 10 gray. And people have shown that it has the same effect.
Thank you very much.
I don't think we have any more questions from the audience, but everybody is grateful for the very informative talks from everybody, and especially from our distinguished speakers.